beautiful second day two of the session. So yesterday, now how is this 3 days? We have Dr. Parag with us. Dr. Parag, yes.
Yeah, hi.
डिलीवरी कर
Yeah.
दीजिए
Good evening. I bring greetings from ICOG, and
Okay.
it's indeed a pleasure to welcome you all on the second day of ICOG certification course on oncology.
नहीं
And
आप
I must
नीलिमा
appreciate
AFC के पास होना
our
होगा AFC और
conveners for this program. Nilima, can you mute others, please?
Yes.
Yeah. I must appreciate the efforts put in by the conveners, Dr. Priya Ganesh Kumar, Dr. Sarita Shamsundar, and Dr. Anjana Chauhan. All of them are accomplished women who are working for many, many years in the field of gynae oncology. So on behalf of office bearers of ICOG, thank you to all three of you for putting up together this program. I'm sure it's going to be of great help to the OBGYNs who are attending. All of us have heard the first day, and I'm sure today we are ready for the second day. So happy learning to everyone. And Priya, over to you for the proceedings.
Thank you, Dr. Parag. Thank you, and let me thank ICOG for giving this opportunity. Dr. Parul Kotradawala, Dr. Parag Beniwale, Dr. Sheila Mane, Dr. Sarita, and of course our Foxy President, Dr. Jaideep Tang, Dr. Madhuri Patel as Secretary General Foxy. So as Dr. Parag just mentioned, yesterday was the first day. Today we are going to talk about the cancers of ovary, of cervix. So today is the day for cervix. And we all know, dear friends, the cervix is one thing which, see, this course is being designed for gynecologists. So I would want to tell over here that we as gynecologists, we actually don't do Vardheims and all that. We limit ourselves to understanding it, staging it properly, and then understanding where to go, how to put it up, and how to treat further, and understanding the fact. So today's day is being designed knowing that cervix is one organ which has precancerous conditions, and that's the forte of the gynecologist to understand that precancerous condition, treating it well, and suppose if she lands up inadvertently into a cancer, to know how to go about with it. So today's course has been designed in such a way is that we're going to talk about the CI and pathophysiology stepwise colposcopy, which is again the forte of the gynecologist. And then interpretation and scoring is another very important thing, along with the screening. And then coming up is the case-based discussion, where we have tried to bring to you all various cases, right from the precancerous to cancerous and advanced cancers as well. So that's exactly where we are going to take the flow into. And today with us, we do have Chief Guest Dr. Bhaskar Pal with us and Dr. Niranjan Chavan as the guest of honor. Can we have Dr. Bhaskar Pal sir's CV, please? So we know Dr. Bhaskar Pal, he has been the president elect, and
Priya, please don't bother. Priya, please don't bother.
2020.
Please don't bother.
Yes, sir. So over to you, sir, for the
Okay.
chief guest.
At the outset, thank you very much, ICOG team, for inviting me as a chief guest for today. I congratulate the Foxy team, Dr. Jaideep Tang, and the ICOG team, Dr. Parul Kotawala, Dr. Sheila Mani, and Dr. Sarita Balerao. It's a wonderful idea to have certificate courses in general. And I can see my dear friend, Dr. Sarita Balerao, has put very, very tough points that you have to score at least 50% in the test in order to get your certificate. So just by putting your name and logging in is not good enough. Oncology is something which is very, very important, especially these days we diagnose more, our women live longer. And so I congratulate the conveners, Dr. Priya, Dr. Sarita, and Dr. Anjana, and all the coordinators. And I'm sure that it will be a great learning experience and it will improve the care of women with gynecological cancers. Thank you very much again.
Thank you very much, Dr. Bhaskar, sir. Yes, now we have with us the guest of honor, Dr. Niranjan Chavan. Can we have the CV of Dr. Niranjan Chavan being displayed? Dr. Niranjan, you're there, I believe. I could see you on the, yeah. So Dr. Niranjan Chavan is a professor and unit chief of LTMMC and LTMGH Sion Hospital. He's been the joint treasurer, Foxy, from 2020 1 to 2023, and now we have 2024. And he has been the president of MOGS 2022 to 2023 with lot many accolades and wearing lot many hats in various organizations. So over to you, Dr. Niranjan, for your guest of honor address. Dr. Niranjan. Nilima, is Dr. Niranjan there?
Yes, sir has joined actually.
Yeah.
Yeah.
So, can you people see me? Yes, thank you.
Yes, we can. Yeah.
Right now, I'm in BKC. I'm going towards, the Geo Convention Center. I see that we have the AICOG coming, and we are all waiting for all of you to come. We have already crossed about 6,500 registrations, and still 1 month for the All India Congress. So on behalf of the organizing team, I welcome all of you. So those ICOG members who are not registered for the conference, please come have a look of our Amchi Mumbai and Chair Nandita Palchetkar, who is the chair, myself as an organizing secretary, and we have 84 members of MOGS. We are all eagerly waiting for all of you to come. So with this, I would like to thank now Dr. Sarita Bhalera, who has invited me, Dr. Priya Ganesh, who is the course coordinator and the conveners, and of course, a team of Parul Kotadawala, Sheila Mane, and Sarita, under the leadership of our president, Dr. Jaideep Dank. And it is a great privilege to be a part of Gynae Oncology course. I was once upon a time about 14 years back with the Gynae Oncology chair, and it's an honor again to revisit them. Presently, I'm driving, and today the Prime Minister of India, Honorable Modi sir, has come down in Mumbai to be the part of our swearing in ceremony, Narendra Fadnavis. So I'm still stuck up in traffic here, and I'm sure I'm going to miss a lot of the lectures which are related to today's topic. And I thank also all of you to join. It's very important. Certificate courses are very important. So it's not necessary and mandatory that we should know surgical skills of Vardheim hysterectomy as told by Dr. Priya Ganesh, but it is very important to detect early cancer, and the rate of cancer incidence has reduced down drastically over a period of time. Once upon a time, I used to operate Vardheims at least 5 to 6 per year. Now I'm operating once, probably 3 to 4 years. So that is a very good sign. And a lot of work has been done in early detection of the cancer. And I'm sure you all will go with a lot of knowledge at the end of this course. And thank you, Dr. Usha Saraya, Madam, our guiding force. She has started this colposcopy clinic. I think more than 45 years have passed. She has been dedicatedly doing this at Kama, and all the members who are a part of this. So, Priya, thank you once again. And I would like to thank so many members. I see Ranjana Madam, Priya, Nivedita Datta, and there are many Niyogi, Veena Madam, and many of them. I can't just go because I'm driving amidst now. I have to be very careful. So bye. All the best.
Thank you, Dr. Niranjan. Great pleasure to meet you. And now we will, I think now the link will be shared. And with us as a coordinator today is Dr. Janani and Dr. Suganya. So over to you, Janani and Dr. Suganya, and let's start the program.
Yes, ma'am. Thank you for the introduction, ma'am. Today I welcome the first chairperson of session 1, Dr. Ranjana Khanna. Madam was the senior consultant and director at Ranjana Hospital.
The pretest link been given? 1 sec, Janani. Is the pretest link been posted?
Yes,
so that will be, yeah.
Yes. Gauri, please post the link in chat box.
So this link is there with you all. Kindly go to the pretest, and then after this, we give you some 5 to 7 minutes. It's all easy test only.
Yes.
We request everyone to fill this, and then in 5 minutes, we will start our program. So I think we have given enough. The time is over, and we can start with our program.
No, madam, still time is there.
Time is
4
there?
minutes. Yeah. 4
Okay,
minutes.
all right.
Yeah, timer is
All right.
on your screen, madam.
Okay.
See.
Thank you. Thank you very much. Yeah. So we all have completed that pre-test, and now over to Janani and Suganya to continue the program.
Yes, ma'am. Thank you, ma'am. I welcome the first chairperson of session 1, Dr. Ranjana Khanna. Madam is Senior Consultant and Director, Ranjana Hospital, and she was the National Vice President of FOXY in 2017. She's the Founder President of ISO PARB Prayagraj in 2021 to 25. She is the ICOG Governing Council member 2021 to 2025. She is an executive member in National ISO PARB 23 to 25. And Madam has won numerous awards, and she has delivered the prestigious Dr. Prabha Malhotra Oration in 2023. And she is also a co-convener of FOXY GCPR on epilepsy in pregnancy. I welcome you, Madam. The next chairperson who's joining us is Dr. Suchita Vivek. She is an MBBS, MS, and FICS FAME Fellow and Fellow in Gynae Oncology. Madam is an Associate Professor OBGYN in Bharati Vidyapeeth Medical College, Pune. And she has a clinical experience of total 30 years, and she has published in various national and international journals. Her area of interest is medical education technology and gynae oncology, and she has received the annual Dr. Harshad Parasnis Award for exemplary work in gynae oncology in Forbes annual conference in December 2023. I welcome you, Madam. Our next chairperson is Dr. Veena Acharya. Madam is the head of Obs and Gynae department and also a preventive oncologist at Rajasthan Hospital, Jaipur. She is the chairperson, governing council, ICMCH, NARCHI. She was the former president, Rajasthan NARCHI, JOGS, ISCCP, and Fertility Society. And she has been awarded the Chikitsa Vibhushan Award on Doctor's Day in July 2018, and her accolades are numerous. And I welcome you, Madam. Over to the chairpersons to introduce the speakers. Thank you.
Yeah, good evening, everyone. Today, I have the pleasure of introducing Dr. Gitanjali K. Amin. She's a practicing gynecologist and obstetrician in Mumbai. Honorary colposcopist cytology clinic she's got in Kama and Albliss Hospital and Vasanta Memorial Cancer Trust. FOXY and IFCPC WHO certified master trainer for colposcopy and treatment with cryotherapy and LEAP. Trained and worked in preventive oncology department of Tata Memorial Center and cervical cancer screening group WHO IARC. Recipient of Golden Jubilee Award AMWI Mumbai and Dr. Sarita Bhalera Award for the year 2023 for excellence in preventive oncology services. So over to you, Dr. Gitanjali. We are waiting to hear you for your talk on pathophysiology of CIN. You are muted. You are muted.
First of all, I would like to thank you very much, Madam. First of all, I would like to thank the organizing committee, Dr. Priya and her team members for giving me the opportunity to be the part of this program. So I'll share my screen. My topic for today is pathophysiology of CIN. So as you all know, globally, cervical cancer is the fourth most common cancer in women, and around 660,000 new cases and 350,000 deaths in 2022. The burden is more in sub-Saharan countries, sub-Saharan African countries, followed by Latin America, Eastern Europe, and Southeast Asia. If you see in India, cervical cancer is the second most common cancer in women in the age group of 15 to 44 years. The age-adjusted incident rates of cervical cancer varies widely across the country. It is the highest in Mizoram, 23 per 100,000 population to 4.9 in Dibrugarh district. Though cervical cancer is a preventable cancer, the natural history of the disease is well known. The primary prevention by vaccination and secondary prevention through the screening program and the treatment of precancerous condition is well known. And the facts have shown that in the Western countries, they could reduce the cervical cancer incidence and mortality to less than 50% through this screening program. Yet, certain factors that contribute to the burden of cervical cancer in the developing of countries are like access to services could be, though it is program in situ, it is access to services, HIV or immunocompromised state, socioeconomic factors, unhealthy lifestyles may contribute for this burden. So coming to my topic, a good knowledge of the etiology of pathophysiology and natural history of CIN provides a strong basis for visual screening test as well as for the colposcopic diagnosis and understanding the principles of treatment of these lesions. See, as you all know, invasive cervical cancer usually preceded by a long phase of pre-invasive disease. This has been characterized microscopically by a spectrum of events progressing from cellular ATPR to all varied grades of dysplasia or cervical intraepithelial neoplasia before progressing into CIN, invasive cancer. To start with a little bit about the anatomy, the cervix is the lowermost portion of the uterine uterus, which is about 3 to 3.5 centimeter in length, and it has got down below. It has got two portions, exocervix and endocervix. Embryologically, it is been developed from the caudal part of the urogenital sinus and the cranial part of the urogenital sinus and the caudal part of the Mullerian duct. The cervix, the developmental era, the cervix, when it projects into the vaginal, it projects down into the vaginal fornix. So the lowermost portion or the cervix is divided into endocervix and exocervix. Exocervix is exposed to the vagina. So it has been lined by the squamous, multi-layered squamous epithelium, and the endocervix is lined by the columnar epithelium. And the junction between the two is the squamocolumnar junction. So the little bit about the cellular structure. The endocervix, as I told you, it's lined by the columnar epithelium. It is lined by a single layer cell, single cell thickness, and the nucleus is at the base, and it is separated from the stroma by the basement membrane, which contain the fibromuscular area with the stromal vessels. And it is been thrown, the surface area is more, so it is thrown into folds. So you get the crypts and so you get the folds and the crypts in between, which can be seen as a gives a grainy appearance as you visualize the endocervix. So it is red in color in the naked eye examination. And when you go to squamous epithelium, unlike columnar epithelium, it is a glycogenated, keratinized, non-keratinized, multi-layered, mature squamous epithelium. It has got multiple layers separated from the stroma by the basement membrane. The cells being basal, it grows, the maturation takes place from base to up. Basal cell, parabasal cell, which has got a cell nuclei is larger than compared to the superficial and intermediate cells. And the intermediate cells are polygonal with a smaller nucleus with abundant cytoplasm, whereas the superficial cells are flattened with a pycnotic nucleus. The speciality about this epithelium is they are estrogen dependent, and the superficial and the intermediate layers, the cytoplasm contains glycogen, which is dependent on the estrogen. So at times in the reproductive age group, all three layers will be there. At menopause, because of the deficiency of the estrogen, there will be a superficial intermediate layers of the cells won't mature beyond parabasal cells. So note the progressive reduction in the size of the nuclei with glycogen being deposited in the intermediate and more superficial layers. This is seen as a seen as a clear space between the nuclei and the cell membranes. So the junction between the two is the squamocolumnar junction. The pathological picture, histology picture, you can see the sudden dip in the surface. The multi-layered cells with the columnar being a single cell. This is the metaplastic area. Squamocolumnar junction. This is the squamous epithelium. It is a pale pink with the naked eye examination. It is pink in color. Endocervix is reddish in color because the stromal vessels can be seen. The reflected easily. So it is pink in color. In case of squamous epithelium, the light has passed through the multi-layer. So the stromal vessel reflection is lesser. So it is pink in color. So location of the squamocolumnar junction varies with the age because it depends on the age of the patient and reproductive the parity, as well as the oral any hormonal exposure, etc. So in childhood, the squamocolumnar junction is at the level of the os. At the adolescence, because of the estrogen and progesterone both being released, so there will be a cervix will be grown more congested. It is becomes more longer and broader. So the endocervix columnar epithelium prolapses out towards the exocervix. So exocervix, the squamocolumnar junction is away from the os. And as the age advances, there is because the vaginal pH is acidic in nature because of the glycogen being there. Dorsal and basilar flora is there. The columnar epithelium well cushioned in the endocervix with the alkaline mucosa. It cannot withstand the acidic pH in the vagina. So the cells being destroyed, so the process of metaplasia occurs. So the squamocolumnar junction again recedes towards the os. So in the post-adolescent, at the age of menopause, the cervix shrinks and the squamocolumnar junction recedes inside the endocervix. It again goes inside. So, and now coming to the squamous metaplasia. What is squamous metaplasia? The squamous metaplasia, it is the replacement of columnar epithelium by the squamous epithelium by a process of metaplasia, by newly formed squamous epithelium. As I told you, the vaginal epithelium is acidic, which the columnar epithelium and the endocervix exposed into the vagina cannot withstand. There will be a destruction of the columnar cells. So the nature takes care. It is an adaptive mechanism. There are many theories and put forth for this formation of squamous metaplasia, which is well accepted is this is the subcolumnar reserve cell proliferation takes place in this beneath the columnar cells. This reserve cell multiplies into many layers. This differentiates into squamous cells, immature squamous cells, and grows over the columnar epithelium. So when the immature squamous metaplasia, there is no evidence of glycogen present. The mature squamous metaplasia, if you see, there is it is well differentiated metaplastic epithelium. It mimics the normal original squamous epithelium, and it is glycogenated, and it cannot be differentiated from the original one. So during this process of metaplasia, what happens? The reserve cell proliferates over the columnar epithelium towards the os in a finger-like projection. As it covers the columnar epithelium, it covers even as I told you, the columnar villi is thrown into folds. So it covers these columnar villi. So you can get to see some islands of columnar epithelium during the formation, and these crypts have been covered or been opened. So it gives rise to the gland opening, crypt openings. And some of the crypts gets closed by this metaplastic epithelium. So this columnar villi secretes mucus. these glands secrete mucus, it gets inspissated and it thus forms the Nebotian cyst. So you can see in this picture the diagrammatic representation of the metaplastic epithelium growing over the columnar villi and forming the metaplasia. See, you can see the original squamous columnar junction and the process of metaplasia. It's white in color and grows towards the os. And this is the immature metaplastic epithelium going towards the os. You can get to see all the features of it. So in this, during the process of squamous metaplasia, you can see in the villi, there are various degrees of metaplasia occurring over the columnar epithelium. Immature metaplasia with squamous epithelium beginning to cover the small crypts. It appears as dots on the colposcopy and is relatively glycogen deficient. It usually stains faintly acetoid white and poorly stains with iodine. So at the completion, you will get a new squamous columnar junction. See, this is the new squamous columnar junction. This is the original squamous columnar junction. The space between the two is the transformation zone. So you get to see the crypt openings, islands of columnar epithelium, Nebotian cyst, and the pale pink. This is at the site of the inner squamous columnar junction, inner new squamous columnar junction. Immature metaplasia is there. If things doesn't work out, it can turn out to be a atypical metaplasia and nasty. Okay, say this thing. So maturation of the immature squamous metaplasia. As you all know, the cervical transformation zone is the primary target for carcinogenesis. So once the immature squamous metaplasia, if the things all turn out fine, it will go, differentiation is complete and normal glycogen containing mature squamous metaplastic epithelium is formed. But at any insult at this stage, maybe could be due to the infection with the oncogenic HPV types or any factor interfering here, can interfere with the growth of the immature metaplasia and turn out to be atypical or dysplastic squamous epithelium. So you can see here that normal squamous metaplasia occurring here, and the junction is the squamous columnar junction. It is the mature, you can see those glycogenated mature squamous metaplasia. Here you cannot see clearly. It is a atypical squamous epithelium. The cervical cancer is the first solid tumor-associated viral infection. It is Dr. Harald Zerhusen postulated the link between the human papilloma virus and cervical cancer. It is a spherical double-stranded DNA virus with 72 capsosmeres. And as you all know, more than 100 different types of HPV strains are there, out of which 15 are oncogenic, and among them are 16 and 18 are highly oncogenic types and cause more than 70% of the cervical cancer. The rest of it is probably carcinogenic. So, as you all know, how does the HPV virus is the sole probable cause of cervical cancer? How does it enter? So the persistent infection by oncogenic HPV types is firmly established as a necessary cause of cervical cancer, and most of the malignant epithelial lesions of the cervix and variable fractions, other genital cancers and oropharynx, etc. So the entry of the HPV virus into the squamous epithelium is the microabrasion. It has got a high affinity towards the basal cell. It directly enters into the basal cell and sets up the infection. And this is usually HPV infection is a reversible infection, usually with good immunities within 8 months to 1 year, it reverts back to normal. But due to some high risk HPV infection, weak immune response, other STDs like chlamydia or herpes simplex, and genetic causes, multiple smoking, long-term use of oral contraceptives, and other genetic factors play a role in the progression of the disease. And
ma'am, sorry to interrupt you. Your time is up, ma'am.
Yeah, 1 minute I'll have to
Yes,
say
ma'am.
a few another 5 minutes you give me. So the precancerous lesion, the concept of precancerous lesion is usually appeared at 1988. Carcinoma in situ is Border picked up this word in 1932, and later we have got Papanicolaou classification, Regan classification use the term dysplasia, Richards classification use the term. It is more specific cervical intraepithelial neoplasia. In 1991, Bethesda classification was introduced, which has got a good clarity on the explanation. The cytological changes, if you see in cervical intraepithelial lesion, it is mainly the nuclear enlargement with various shape and hyperchromasia. Abnormal nuclei is seen in the superficial and the intermediate cells in the low-grade lesions. In the high-grade lesion, the abnormality is seen in the nuclear parabasal and basal cells. The other changes will be taught in the cytology classes. And about coming to the pathological changes in the low-grade lesion, if you see the low-grade lesion,
Can you slightly quicken up, because
yeah,
we've already shooted the time.
Yeah, low-grade lesion is confined. It's a proliferation of the immature metaplastic epithelium of the lower 1/3 of the epithelium. You can see in this, and superficially you can see some coilocytes in this picture. And in the high-grade lesion, it is a lower 2/3 of the epithelium is involved by the dysplastic epithelium. In the high-grade CIN3, the full thickness is involved in this. This is mainly a progressive disease. CIN1 and 2, it is a productive disease. So in pathophysiology, this is an important slide. If you can give me to this thing. See, this is very important. As I told you, it is a multi-layered in the lower epithelium. When the acetic acid test, the concept of acetic acid test, it is a acid protein reaction. In the dysplasia, what happened? The enlarged nucleus is there. When the acetic acid applied in the mild CIN1 or the low-grade lesion, it has to penetrate through many layers. So acetotype changes comes delayed and it is mild. Whereas in the high-grade lesion, where the full thickness is involved, it appears fast in the dense acetotype lesion. And the vascular changes we've seen, I have seen this, told you the stromal vessels. And it because of the proliferation of the epithelial cells, it get compressed and form stromal papillae. And in the end-on view, appear as a punctation. And this stromal vessel congestion, as well as this compression, gives the end-on view of mosaicism. So this is the normal T-zone as well as the abnormal T-zone. We get to see all the vascular changes as the epithelial changes.
Excuse me, ma'am. Sorry to interrupt, ma'am.
Yeah. Okay.
The time is over, ma'am.
So
Thank you, ma'am.
Hope I've given you the concept of pathophysiology of CIN. Thank you. I'm sorry
That was a very nice talk, though you had to be interrupted. But Dr. Gitanjali, you explained the histopathology very well. I must say that the pathophysiology became crystal clear, and I went back to my original MBBS days when we used to read the histopathology. So very well done, and you explained the basics very clearly.
Thank you. Thank you very much.
So I think now, if after understanding the pathophysiology, which is very, very important, we will be moving to the next this thing on how to do a colposcopy now. So
I invite Dr. Suchita to introduce the next speaker, ma'am.
Yes, with immense pleasure, I introduce Dr. Bhagyalakshmi Nayak. She is a professor, HOD, Department of Gynec Oncology at Cuttack, and she is Honorary Secretary, AGOI, Chairperson of Oncology Committee, FOXY 18 to 20. She is Surgeon par excellence. She has really so many good positions to her credit. She has got whooping 64 plus publications to her credit, and she has won Dr. Usha Saraya Oration. So it's our pleasure to have you, ma'am.
Thank you,
And
thank you.
we are
Thank you so much.
really looking forward to listen to you
Yes,
on
yes.
stepwise colposcopy.
Sure, sure, sure. Thank you so much. Thank you, Priya, Ranjana madam, and all of you. Thank you, Suchita. So just taking a minute to share my screen. So is it visible now?
Yes.
Yeah.
You can put on slides, Dr. Shona.
Yeah. So just a correction, I am no more the HOD because it's a rotational post. So I'm only a professor now. So we'll be talking about step-by-step colposcopy. So I think we have been very clear about how actually the changes happen and what is the basis of all the changes. So now we want to see all those changes in a more clearer way through the colposcope, because it will be an enlarged image of what you are seeing with your naked eye. So there are a set of indications for colposcopy. Not every patient needs a colposcopy. So whenever you have abnormal test, because the test actually detects the crime, but the colposcopy actually tells where is the site of the crime. So all VIA positive lesions may need a colposcopy, HPV positives would need a colposcopy, and all suspicious looking cervix may need a colposcopy, and suspected precancers. So when you have an unsatisfactory cytology that comes again and again, then I think there's a definite indication for colposcopy. And when you have a HPV positive lesion, that's again indication for colposcopy. And now that we are moving from VIA to HPV screening, so I think colposcopy is an indication when you have a positive result on 16 or 18. So we go directly to colposcopy. So again, these are WHO guidelines, which also tells that even if you do a cytology, get some results, but then if you have anything more than ascus, colposcopy needs to be done in these women, surely. So again, if it just ascus and HPV positive, and then again you would need to do a colposcopy. So similarly, these are all the indications. So the three main questions when performing colposcopy is the examination adequate, and where to take the biopsy from, and main is about can I rule out cancer. So these are the three main questions that we have to answer when we are planning to do a colposcopy. So training and expertise is very, very essential, and then it will come with training, and of course then by doing also, because as many times as you start doing and then looking back at your pictures, then correlating with histopathology, then you actually learn more and more. And of course prevalence of the disease is important, and I think India has no dearth of these patients. Referral screening test report is very important. You should know where to send the patient after you have a report, and identifying the grade of abnormality. So now colposcopy has become actually high tech. Now we have this digital colposcopes and with learning colposcopes, and you don't have to initially, when you used to, we have to lean down and look into the cervix through the lens, but now you can look at the bigger picture on the screens and save the picture. So usually they are all binocular, and we have automatically systems zoom in and zoom out, so that automatically the picture increases in size or reduces in size. So these are all newer colposcopes which are actually coming to the market, which are handheld colposcopes, AI aided colposcopes, pocket colposcopes, and mobile optical diagnostic technologies, or ODTs. So the many types of smaller colposcopes are now available in the market. And so here you can see, this is the closer picture. The camera and the light source are all embedded in the front, and this is the panel where you have the there's a timer when you apply acetic acid that comes on the screen. You have a white green filter. Along with that, you can freeze, and you can do a zoom in or a zoom out. Everything can be actually managed. So a green filter, the button, when you push it, you have a green colored light coming in. This is used to highlight the vascular patterns and demarcates color differences between normal and abnormal tissue. So this is the trolley which should be ready whenever you are planning for a colposcope. All sizes of speculums are important. An insulated speculum is welcome, and you should have, if you are planning to do a biopsy, you should have everything ready, a punch biopsy or a tisular biopsy. Then these are the Lugol's iodine should be ready, acetic acid, normal saline, everything should be kept ready. And so these are the cautery cord and everything which has been kept ready. So basically, you would need a biopsy forceps, endocervical curette, endocervical brush, cytology brush, and silver nitrate stick may be required in case there is bleeding, Monsell solution. And sometimes you should keep a condom also ready in hand. I'll tell you why. So these are the instruments. This is a small curette, and this is a Kervokian young biopsy forceps, which is a little different from the cervical punch biopsy forceps, because that crushes the tissue, and this will not crush the tissue, and this is sharp and will cut from a low grade or a high grade lesion when there is no apparent or obvious growth. And these are the cytology broom, endocervical brush that will be required to take cytologies. And this is lugolsardine, and Monsel's paste is a styptic. When there is mild bleeding, if you can apply Monsel's paste, then the bleeding stops. And silver nitrate stick also does the same thing. So the procedure history taking is very, very important. I think you have to take the history very properly, everything, and a bit about the pregnancy test, about the LMP, everything should be taken. And it's better that the woman should not be bleeding, because it becomes really messy if you are doing a colposcopy when she's bleeding. And the procedure has to be explained to the patient, and all the questions should be answered. Then signing a consent form is good practice. And colposcopy is performed in a dorsal lithotomy position. The speculum is placed in the vagina after the vulva is examined. So I think it's very important. You have to remember that, because this is the one chance you will get for the vulva to be seen. Just one second. Okay, so I think this is the best time that you have to look at the vulva, because that's a good light in your hand. So don't overlook the vulva. That's very important. And then before you put in the speculum, it's very important to choose the size of the speculum, because once the patient is uncomfortable, she doesn't cooperate, that 5 minutes will become 20 minutes and you will really have a very tough time. So choose the speculum according to the size of the woman's introitus, because in postmenopausal women, you have to choose a smaller size speculum, and especially women who already have a cesarean section, not a normal delivery. So be very cautious about that. And then a speculum is placed. Maybe you can just lubricate with a little of a normal saline in the vagina after the vulva is examined for any suspicious reason. Then you orient the colposcope. First, you have to see the cervix totally on the speculum, that you see that the entire cervix, you can see the cervix. Then you orient the colposcope so that a panoramic view is obtained, and start with a normal light and a 10 times magnification, and then the entire cervix should be visualized. So this is the position that a patient should be put in, but then patient should be very comfortable. And 25 centimeters from the patient's perineum is the ideal distance that this colposcope should be placed at. Focus to see the entire cervix and the fornices. Please don't forget to see the fornices, because if you focus only on the cervix, there may be a hidden lesion in the fornix. So use a sponge holding forceps to move the cervix from the medial, so move the cervix to the right to see the left fornix, and move it to the left to see the right fornix, and move it up and down to see all the fornices. So all the fornices need to be seen. And then, as I have told, you can then zoom in, use the green filter, and all those things can be done. So focusing is first important. Then comes application of normal saline. Normal saline is used to move out all the dirt or discharge or mucus from the cervix. Then application of acetic acid, that is 3 to 5% acetic acid. And then comes application of lugolsardine. So the lateral vaginal wall retractor may sometimes be required when the lateral vaginal walls are falling down, or otherwise a finger of a large glove can be used, truncate the tip, or a condom can also be used. So put the speculum into the condom and cut the end of the tip of the condom, so that the condom is helps you to keep the lateral vaginal walls away from view. And the assessment, the squamous epithelium is pink. Dr. Gitanjali has explained this very nicely. Squamous epithelium will look pink, columnar epithelium will look red, and we have to identify the squamo-columnar junction and the transformation zone. So the area between the new and the old squamo-columnar junction is the transformation zone. So it is important to identify the squamo-columnar, the transformation zone, because 99% of the lesions do arise from this transformation zone, because it's a very dynamic thing, and the cells there keep on regenerating and keep on moving from squamous to adeno. So that's why that is important. So proper placement of the Cusco, as I've told, size of the Cusco is very important. You need to decide that. Woman should be comfortable. Cleaning off all obscuring mucus or discharge using cotton swabs soaked in normal saline. Apply generous amount of 3% acetic acid over the cervix, you have to be very generous so that you almost bathe the cervix continuously and wait for 1 minute. That is very, very important. And there is a timer on the colposcope that comes on the screen. So 1 minute you have to wait for that. And areas of acetowhiteness will correlate with higher nuclear density. And the main aim is to look for the squamocolumnar junction and the transformation zone. And an adequate colposcopy examination is the ability to see the transformation zone and the entire extent of any lesion through totally, completely. After a complete examination, areas with the highest degree of visible abnormality, that is aceto-white lesions of abnormal vascular pattern, is biopsied by the punch biopsy forceps. If no lesions are visible, then an iodine solution may also be applied to the cervix to highlight the areas of abnormality. Anesthesia is usually not necessary. However, using a topical anesthetic such as a lidocaine or a cervical block to decrease patient discomfort, particularly if any biopsy samples are being planned, it's ideal to put a xylocaine spray on the cervix so that the woman does not feel any pain at all. So adequacy of colposcopy is that you must evaluate the entirety of the lesion. Can you follow the entire lesion? Does it go past the squamocolumnar junction into the endocervical canal? Does it move into the vagina? So all these things have to be answered. Must evaluate the entirety of the squamocolumnar junction. Is it obscured by prior treatment? Does it recede into the endocervix? So proper evaluation of both the lesion and the squamocolumnar junction is an adequate colposcopy. Failure of either criteria is an inadequate colposcopy. And so here we apply 3% acetic acid. Cervix is viewed under magnification and green light, and the entire transformation zone must be visualized. So here you can see that the inner one is the original squamocolumnar junction. And here you can see that this is the endocervical os, and this is the new squamocolumnar junction. And so the area between the old and the new squamocolumnar junction is the transformation zone. So aceto-white change, what do you look in the transformation zone? You look at aceto-white changes. Are they small or large patches? Does it have a sharp or indistinct border? Areas of punctation, areas of mosaicism, and abnormal blood vessels. So I think all this will be told in detail in the next lecture. So inadequate colposcopy is one when you cannot see the cervix properly, maybe due to scarring or maybe due to previous surgery. So when you cannot see the cervix in its totality, so that is the inadequate colposcopy. So when you are able to see then in the total cervix, then you find out whether it is a type 1 transformation zone when it is entirely seen and the new squamocolumnar junction is totally on the ectocervix. So this is a type 1. This is called a type 1 transformation zone in which you can see that the new squamocolumnar junction and the old squamocolumnar junction are all visible very clearly, and this is the entire transformation zone we can see it properly. Type 2 is one where partially it has gone into the endocervical canal, however, with little manipulation, however, by little using of the endocervical speculum. So this is called endocervical speculum. You can see the extent of the squamocolumnar junction if it is entering into the endocervical canal. So this is called the endocervical speculum. And here you can see that the endocervical speculum has been put into the endocervix, and you can see that the squamocolumnar junction can be visualized inside the endocervical canal. And this is a squamocolumnar junction. Sorry. This is a type 3 transformation zone when the entire thing is inside the squamocolumnar junction. And so here you can see this is a very clear type 1 zone in which the entire lesion margin you can see here very nicely. So here this is the squamous epithelium. Red is columnar epithelium. And here you can see these are patches of squamous epithelium which is actually growing like waves, and this will gradually fill up this entire columnar epithelium. So here you can see these are waves of white epithelium which is coming from the squamous epithelium, which will gradually cover up the entire columnar epithelium by layers. So this is again a normal colposcopy, and this is a normal colposcopy. This is called ectropion because this is a very benign thing, nothing to worry about. And here this is squamous epithelium and red is columnar epithelium. So what are there any complications of doing a colposcopy? Significant complications are very, very rare. Bleeding, infection at the biopsy site or endometrium may be sometimes there. Failure to identify the lesion. But the main thing is that especially when you are doing in post-menopausal woman, we should be very careful because we are not very careful, sometimes vaginal tears do happen, and especially because they are atrophic vaginitis, the vagina is thin. And monsoon solution and silver nitrate may interfere with interpretation of the biopsy specimen. So these substances should not be applied until all biopsies have been taken, and there could be some discomfort during the curettage and the biopsy. So we have to counsel the patient accordingly. But there is no absolute contraindication. Patient's ability to tolerate a standard
Ma'am,
speculum
sorry to
examination is
interrupt
the
you.
only. I finished. I'm done.
Yeah.
The patient's ability to tolerate a standard speculum examination is the only true limiting factor. Active cervicitis, vulvovaginitis should be treated before undertaking the examination, and inflamed tissue can alter the ability to obtain an accurate assessment. So there are some ethical
I'm sorry to
consideration, as I've
interrupt,
already
ma'am.
told.
The time's up, ma'am.
Yeah, I know. I'm just finishing. So conclusion, colposcopy is a valuable tool in all gynec practice for diagnosing, monitoring, and managing cervical abnormalities, and addressing the indications, challenges, and advancements in colposcopy requires multifaceted approach. Future of colposcopy, of course, lies in artificial intelligence and precision medicine. Thank you very much for giving me this opportunity.
Thank you, ma'am. That was really very crisp and to the point talk. May I add one line that it is always a good thing to practice on inanimate objects first before actually going on and practicing on the patient. Yes, that was very nice
I just
talk.
wanted to
Really.
say one thing, Bhagilakshmi, that
Yes, madam.
point that you put across, when we are seeing the cervix, we are only focused on that. But you said that first see the vulva. So that point is very well taken.
Yes.
That we should have a all-round vision. It should not be just focused on cervix if you are seeing that.
Yes.
Because then we won't miss the vulvar
Yes,
view.
madam. The vulva and the fornices. So
Yeah,
those are the
yeah.
things I
Yes.
always tell my students. You should also look at
that
the
is very,
fornices.
very important, that you should only not go for the ectocervix, just examine the ecto and endo and be done with it. We should see it in
Yes,
totality.
it was very nicely conveyed.
Yeah.
Thank you so much.
Thank you.
So after the steps of colposcopy, very well taken up by Dr. Bhagya. Again, adding up, you can also do vagina. So when you take in total, everything can also be
Yeah.
done. So
Yeah.
now we go to the next talk. Over to Suganya and Janani.
Yes, ma'am. Thank you, ma'am. I invite the next chairperson, Dr. Veena, ma'am, to introduce the next speaker.
Am I audible? Yeah. Very good evening to all. Very good evening to all. It is a matter of great pleasure to introduce such a dynamic lady, Dr. Priya Ganesh. Everybody knows that she is the chairperson of Gynecology Oncology Committee of FOXY. And Dr. Priya Ganesh is the medical director of Srinivas Healthcare System. Dr. Priya Ganesh is well known in the field of the gynae oncology, and she is the master trainer for which is by the WHO, IRC, IFCP for the colposcopy and cytology course all over the India. Dr. Priya has done wonderful job for the HPV vaccination project. A grand success under her leadership is the almost 10,725 gynecology HPV vaccination. The FOXY champion, she has prepared all over the country. That is big congratulations to Dr. Priya Ganesh. And Dr. Priya Ganesh has also Ayushman Bharat project in the state of the MP and the Gujarat. And she's also held so many books under her credit. She is the editor of the FOXY book of the update in gynae oncology, editor of the FOXY focus of the HPV, and convener of the FOXY GCPR on prevention and management of the cervical. That is a big guide for all the gynecologists in the India who are not much aware about the oncology, especially for the preventive oncology. I must say about the Priya Ganesh that she is not only she is dedicated only for this, she's also awarded from the Health IMA Excellence Award in 2019, Asian Pacific Medical Excellence Award from the International Institute of the Education and Management of IAC. And Dr. Priya Ganesh, as a visionary leadership under the chairperson of Dr. Priya Ganesh, she has left no stone unturned for the prevention of cervical cancer. Her tireless effort at a grassroots level for the prevention of cervical cancer, her big slogan for the cervical cancer Mukt Bharat. It is my privilege to invite Dr. Priya Ganesh because her journey is unremarkable and she's doing such a wonderful job for the prevention of cervical cancer. We are privileged to have Dr. Priya Ganesh with us, and all are the privileged to listen her because we already listened Dr. Bhaglakshmi to discuss this step-by-step colposcopy, and Dr. Priya Ganesh is going to discuss about the colposcopy interpretation and scoring. So you will be update about the colposcopy. Dr. Priya Ganesh.
Okay, am I audible? Yeah.
Yeah.
So thank you very much, Veena madam, for that elaborative introduction. So as we have been now going through the journey of colposcopy, one thing that I want to say is vision is the art of seeing, which is invisible to others. That's exactly what colposcopy does. Because colposcopy makes us understand this submerged part, which is actually extremely important for any gynecologist. And we have been seeing from 2018, these are the reports. Globacon, you can see over here 96,000 initially has rose to, every state has shown an increase. With the Globacon 2020, again, that it has shown increase to around 123,000 from 99. Then in Globacon 2022, again, it has shown increase to 127. Now, when we are talking about HPV, it is an HPV is not only causing a cervical cancer, but also causing various other cancers like anal, vulvar, vagina, penile. So now that is what exactly Dr. Ranjana and Dr. Bhagya just mentioned to you all, that whenever you're doing a colposcopy, don't focus only on that cervix, look at the fornix, look at the vagina, look at the vulva. Also, going up ahead from there, get the anus also. Nowadays, we are getting a lot of people with anal warts. So anal colposcopy is also picking up. And hence, it is not only one organ which we are looking as a colposcopist, but looking at various other things as well. And now, if you see this Globacon 2022, the new cases has further increased. So now it is really pertinent for all of us as a gynecologist to look into the cervix, understand colposcopy in the better perspective. Prediction for India is if no intervention is done, you can see 57 lakh women would be dying in cervical cancer by 2070 and 131 lakhs by 2120. So this is the prediction. And then we do have all these, right? 90, 70, 90, which has come up from the WHO as a global strategy for prevention of cervical cancer. So when we are talking about colposcopy, it is a 70% portion, which we are actually 70% of the women should have undergone screening, and screen positives undergoing for further colposcopy and management. So if these pillars are taking up very well, then we will be able to avert 1 lakh deaths due to cervical cancer next decade and 10 million deaths by next century. So colposcopy, very well shared by my previous speakers. Now we do have binocular, we have video colposcopes also. Hans Henselmann was the German scientist, gynecologist who invented colposcopy in 1924. And he did a lot of work onto it. Singer Monahan came up saying that colposcopy with a directed biopsy is the gold standard for diagnosing of cervical precancerous conditions. Indications was very well covered by Dr. Bhagya. The screen positives, unhealthy cervix, and now another term has come up in the ASCP guidelines, which said like risk stratification symptoms also should go in for a colposcopy. Even though if they are screen negatives also doesn't matter, if only risk stratification, like, when will you say repeated white discharge? If it is at least 4 times in a year in spite of treatment, they will go straight for a colposcopy. Postcoital bleeding, postmenopausal bleeding, intermenstrual bleeding. These are the things where you straight away take her up for a colposcopy. Now, colposcopy instruments, I have been always telling all my students and my colleagues, whoever attended my courses, without having a proper set of instruments, please do not jump in to do a colposcopy because you might miss out so many things. So colposcopic instruments should be having, like what Dr. Bhagya said, ensheathed condom. Sometimes a lax vagina, you have this condom ensheathed. Then you have different types of sim speculum, Cusco speculum. Now, biopsy forceps, extremely important. Tissue biopsy forceps are very good. Endocervical speculum, again, TZ3, what will you do without an endocervical speculum? You have to have that. Then this is one of my own patented instrument, which was patented by me with a patency number. So this is PGK tissue holding forceps. If you want to do LETS, or if the cervix is flushed with vagina, what will you do? How will you hold the cervix and pull it? So this was one of the patented instruments which was designed. Then endocervical curette is there. This all has to be there. Again, you can see this. This is a vaginal retractor. So with all these, you begin so this was the PGK traumatic tissue holding forceps, which had come in the yearbook of our Foxy, doctors who have invented that, this thing. Instruments. Now, diagrammatic representation is extremely important. Whenever we have done a colposcopy representation. So you will be doing a Cartier-Cartier diagram. This is the dotted lines which will identify SCJ, original SCJ. The bold line will represent new SCJ, and in between is a transformation zone. Whenever you're giving your sample for biopsy, or you're giving it for even for this thing, please draw this diagram and put a cross key from where did you take up the specimen. Now, another very important thing is reporting system. I have seen many people coming up only with the colored pictures without reporting. So that's again something which should not be done. So new IFCPC nomenclature to the cervix is one of the this thing, and this is scoring system. So what do you have both combined? You have a reporting system which you will document all that. Then you will score if there is a lesion. So this is a quantitative way and a qualitative way of putting a report of the patient. IFCPC is International Federation for Cervical Pathology and Colposcopy. And this federation they contribute to standardization of terminologies and evaluations and all that. Now, let's see, this is the latest one. After that, there is no update as of now. So, general assessment, when you talk about a colposcopy, first thing what you put is adequacy, inadequacy. Adequacy, whether you're able to see the cervix well. So, inadequacy, so here we have general assessment, normal colposcopic finding, normal colposcopic finding, suspicious for invasions, and miscellaneous. So, I have brought few books from my own textbooks, from my own work, I have brought just to make you understand how do you do this, understand these terms. So you have general assessment, adequate colposcopy. It's very nice. We can see it completely. Inadequate because it is bleeding scarring. Then you will write the second point would be SCJ completely visible. So you will put it up as TZ1. SCJ partially visible, TZ2, and USCJ not visible, TZ3. Then you will put for normal, if there is a normal colposcopic finding, you will say it is a mature colposcopy. Here you see, Dr. Gitanjali had spoken about islands of columnar epithelium. So you see, this is an island of columnar epithelium. Then this is an atrophic epithelium. This is an ectopy. This is an ectropion. What is the difference? Ectopy is the physiological 3/4 of columnar epithelium covering 3/4 in the cervix. Whereas ectropion is, there is a lateral tear postpartum, and so there is an eversion. And hence, in both the conditions, your columnar epithelium is occupying 3/4 of the cervix. And then this is a metaplasia. Then you have over here, Nebotian. Then these are crypt openings, deciduous in pregnancy. Whatever you're finding, you please put it up. Then abnormal colposcopic finding, you will talk about lesions. These are the thin lesions you can see over here. Size of the lesions can be mentioned. Then these are the fine mosaics, and then these are usually fine mosaics and fine punctations. They do not mention the high-grade lesions. They would be normally also seen in an atrophic epithelium. You might see fine mosaics and fine punctations because of atrophy. Then dense acetobite areas you can see over here. And then there are the mosaics over here. So these is what you will be mentioning. Further, you can also mention about the leukoplakia. You can mention about the condyloma if ever you are seeing it. And then here is where we are talking about erosion. So you see this abnormal colposcopic finding has got location of the lesion, location by clockwise fashion. Then qualitatively, you are mentioning whether it's a thin acetobite area. Then you are saying whether it's a dense one, what is the rapid appearance. Then you will talk about non-specific findings like leukoplakia. Like, why is this leukoplakia very important? Because there can be a hidden HSIL. So you might have to take a biopsy. Then you will talk about the Schiller's iodine stained or non-stained. Then suspicion of invasion is atypical vessels. You can see over here. These are the waist thread type of patterns. And then these are the rack signs. You can see over here. Lesion within the lesion is called as an inner border sign. All these are suspicions of invasion. And then here is an ulcerations you can see over here with abnormal vessels. Then, so whenever you have the abnormal vessels, you'll talk about the dense acetobiteness, Lugol's, what is the positive, whether it is villi positive, that is a mustard staining, or it is a yellow, canary yellow staining, along with the abnormal vessels, which you would have seen. Miscellaneous finding, congenital TZ. So here you see, This is that acetovite area even going to the anterior and the posterior fornices also. Then this is the condyloma. These are the polyps which you can see. These are the congenital anomalies you can see. So whatever you have seen, you will be mentioning it. Then talking about this is a cervical endometriosis. This is cervical fibroid. These are infected Nabothians. These are these are the punched ulcerative things like herpetic patch things. So whenever now what you have done, your first work is over. We have reported it. Now you found a lesion, you have to score it. Now scoring has come up with the Reed scoring system, which has 4 parameters: color, acetoviteness, margins and surface, vessels, and iodine staining. Total Reed scoring is 8. And so now the latest one, I mean, what we are all teaching and what we have, and we find that this is a very comfortable, observers, is the learning curve is low. So you have 5 parameters: acetoviteness, that is sweet scoring. Nowadays, we are all doing sweet scoring: acetoviteness, margins, vessels, lesion size, iodine staining. And then how do you interpret this? This is a total score of 10. So 0-1 becomes chronic cervicitis or even sometimes metaplasia. 2 to 4 is CIN1 L-cell, 5 to 7 is SIN2 HSIL, and 8 to 10 is CIN3 HSIL. So you have SIN2 plus or SIN3 plus with these 5 parameters numbering from 0, 1, and 2. So you have acetoviteness, 0 transparent, shady, milky, neither transparent nor opaque, distinct white. And then your margins diffuse. Here it is sharp but irregular jagged margins, even satellite lesions. This is the difference, like the difference between the size. Then you have the sharp margin but difference of level. So raised things or raised margins. Now vessels, fine, regular is 0, absent is 1, coarse is 2. Lesion size less than 5, or you can also talk as quadrants. 5 to 15 or 2 quadrants, above 15, 3 to 4 quadrants. Sometimes it goes endocervix. You will again put up as a higher score of 2. Iodine staining brown, faintly or patchy yellow, and distinct yellow. Now let us see cases now. Here is one case. Here acetoviteness is 1. Margins are irregular and jagged, so we are giving 1. When we talk about the vessels, now here there are fine mosaics, and these are the fine punctations. So it doesn't matter, we'll give it a 0. Then this is in 2 quadrants, so we give it as 1. And for Lugol's, we give it as 1 because it is patchy yellow. So here the total has become 4. And as I told you, we're going back to our understanding of sweet. Here we have 4 is CIN1 L-cell. So there is here now a concordance. You can see there is a great concordance. Our histopath has come up as CIN1. Then we go to another case. Here we have, now let's start again doing the sweeting. Here you can put 1. Then you can put the margins slightly raised. You can put as 2, 1 plus 2. Then here there is an absent vessel. And here there are coarse vessels. You can err on the lower side. So you can put as 1. So 1 plus 2 plus 1. This is there in all the quadrants. So you put it up as 2. And again, patchy and faintly yellow. So you can put it up as 1. So total score comes to say 7 or 8 oblique. So down here the histopath is CIN2. So there is a concordance. Coming up to this, you have a dense aceto-white, raised margins. You can see over here. Then you have this as the vessel patterns are mosaics. And then is there in the 2 quadrants and patchy. So here I have put it up as 2 plus 2 plus 2 plus 1 plus 1, which is 8. Histopath is CIN3. That is great concordance. You also have, say, suppose if I give this case, invasive squamous cell carcinoma. You see, these are the dense aceto-white. These are raised margins, and you can see different blood vessel pattern. So this is a corkscrew type of pattern. This is a widened hairpin pattern, the waist thread pattern, and mustard yellow and all that. Total score is going to 10, and the histopath is invasive CA. Now, do not forget adenocarcinoma. We have the habit of only looking into the ectotransformation zone. No, you have to understand as a colposcopist the difference between a metaplasia and a actual lesion. A metaplasia will have, sometimes people forget to see this and they think this is a metaplasia. It cannot be. So, because metaplasia has the quality of transparency, translucency, appearing, disappearing fast. Now here, and also abnormal blood vessel pattern is there. These are opaque. These are not translucent. They are dense. They're having abnormal vessel patterns, and it's going endocervix with this thing, muster staining and all that. So this is coming total to 10, and this is called as adenocarcinoma in situ. Now, and our understanding becomes, Foxy GCPR has brought you how to go about with this also. That's extremely important. I was very lucky to be as a convener along with Dr. Bhagya as a co-convener to formulate this along with my team members. So thank you, Dr. Pai, to give me the opportunity. Now, in Foxy GCPR, we have all these things. I'm sure you all would have had it. You start screening at 25 and end it at 65. And then understanding becomes very important is whenever you're screened and you know what to do with it, how to go about it. That's exactly where your work comes up. So in a good resource setting, you can use HRHPV or cytology in acceptable VIA, low resource setting, no HPV or this thing. The main understanding is why we understanding doing all that. If there is a primary screening, HPV is coming positive, you should know how to go about with it. That's extremely important. So if there's positive, so this is screen and treat. In a screen and treat or in a screen triage and treat, you will be identifying, like say, suppose, how should I treat? That's very important. So sweet scoring and all can come out very here. If there is a suspicion of lesion, say above 8 to 10, no, don't go for treatment. Take a biopsy. Don't be in a big hurry to do a single visit approach. And otherwise, you can take it up. I'm sure my colleagues now in the following lectures will be taking up with primary cytology. How do you go about? Or screen triage and treat, how do you go about? So we are not on the dead end. We have an alternative endings. This was a disclaimer. I brought it from my own textbooks. And with the scientists to acknowledge George Papanicolaou, Hans Enselman, Harald Zurusen, and Ian Fraser. So, cervical cancer Mukta Bharat, the dream is turning into reality. Thank you very much for patient hearing.
Thank you, Dr. Priya Ganesh, for wonderful talk. And I think so everything is clear after the Bhaglakshmi's explain everything step by step. So everybody is well known about the colposcopy. If anybody have any question or query, they can just put in the chat box and then we will discuss later on. Thank you so much, Dr. Priya. I think so we have waiting for next session.
Yes. So after the session 1, we are now going to session 2. Thank you very much, Dr. Veena Acharya Madam, Dr. Suchita, Dr. Ranjana for chairing the session.
Dr. Priya, I must congratulate today. The participants are more than 205. So it is a good, very good.
It's a remarkable. People are wanting to learn. And thank you all the speakers, Dr. Geetanjali, Dr. Bhagya. Over to you, Janani, Suganya, to carry on for the second session 2.
Yes, ma'am. We will move on to the second session. I will invite the chairperson for the session 2, Dr. Bharati Maheshwari, ma'am. She is a professor and head of Obs and Gynae and IVF in Muzaffarnagar Medical College. And she is a chairperson Foxy MTP committee 2018 to 20. And she has various accolades. And I invite her for this session. The next chairperson will be Dr. Pratik sir. He is an ART consultant and gynae endoscopic surgeon, Ashirwad IVF, Mumbai. And
can we ask everyone to mute, please? Yeah, kindly go ahead.
He is the recipient of numerous prizes and awards, and he is also a peer reviewer in the Journal of Obstetrics and Gynecology of India. Over to the chairpersons to introduce the speakers.
Good evening, everyone. Can you hear me?
Yes, ma'am, we can hear you. Please go ahead.
So it's Dr. Bharti here, and with me, co-chairperson Dr. Pratik Tambe is here. So first of all, congratulations, whole ICOG as usual for keeping a very important topic, that is certificate course on the cervical cancer prevention. And we all know that for so many of years, we are trying to screen the cervical cancer. And of course, pap smear, it is one of the very basic investigations. And if it is doing properly, and if interpretation is done properly, then we can find out the many cases that they can be further investigated for cervical screening. So for this cytology, we have none other than a very renowned gynae oncologist, Dr. Mala Srivastava, that she's a consultant at the Ganga Ram Hospital, New Delhi, and she is a very renowned Foxian, have lots of academic contribution in her credit. So to Dr. Mala for the further session and Dr. Pratik Tambe, if you want to say something.
No, ma'am, I think we can go ahead. We're already behind time. Over to Dr. Mala.
Thanks, the chairpersons, for your nice introduction. It's my pleasure and privilege to talk on cytology and cervical cancer. We all know the Globocon incidence, 6,62,000, and mortality, 3,48,000. And incidence of cervical cancer in India, we see it's almost 1,23,000 cases, new cases, and 11,000 deaths. In May 2018, WHO officially launched the global strategy on 17th November of 1990. And we know women living with HIV are 6 times more likely to develop cervical cancer compared to women without HIV. And an estimated 5% of all cervical cancer cases are attributable to HIV. So there are 3 approaches to cervical cancer screening and future test: molecular, cytological, and visual inspection. Molecular, we know HPV DNA, HPV mRNA, DNA methylation, protein biomarkers, HPV antibodies, and oncoproteins. Cytology, conventional pap smear, liquid-based cytology, and now comes dual stain cytology to identify P16 and Ki67. And of course, there are visual inspection via villi, automated visual evaluation of digital images. So George Papanicolaou started the pap smear, and that has actually brought down incidence of cervical cancer in the Western world. And there is a space for liquid-based cytology as well. There is a FOXY screening recommendation. When to start screening: 25 years in good resource setting. Universal recommendation is 30 years. When to end screening: 65 years with 3 consecutive negative cytology or 2 consecutive negative HPV tests within 10 years. The most recent test should have been performed within 5 years. Test with screening interval, when we are doing with HPV testing every 5 to 10 years, and in limited resource setting at least twice in a lifetime, 35 and 45 years. Cytology every 3 years via every 3 to 5 years. Screening after hysterectomy with removal of cervix not recommended unless the hysterectomy was done for cancer or pre-cancer. And in immunocompromised women, start at 25 years to be screened more frequently. Between 2 screenings should not be extend beyond 3 years. So what is the collection? How do you do the pap smear collection? I'll talk about conventional paps and then LBC. Criteria for accurate sampling, adequate preservation, complete evaluation, and of course, there has to be meaningful interpretation of the pap smear. Optimal sample should contain squamous cell, endocervical glandular cells, metaplastic cells to demonstrate that the transformation zone has been nicely sampled. According to ACS, the ideal time for collection of pap smear is 5 days after the menstrual period. It should not be performed during menstruation except in cases when the patient is experiencing abnormal vaginal bleeding. But we can take with LBC, we can, if possible, especially if you are doing opportunistic screening, we can take LBC during menstruation or when there is a bleeding per vagina. We take eye spatula. Pap smear is taken with eye spatula or brush, plastic broom, cotton swab. And eye spatula is used to sample the ectocervix. The contour end of the eye spatula which best fits the anatomy of the ectocervix and its transformation zone is selected while maintaining tight contact with the ectocervical surface. And endocervical specimen is taken either with the pointed eye spatula or side to brush. If we are taking sample from the pregnant woman, then it's better to take with the pre-moistened cotton swab applicator. Transferring is very important. Smear the spatula on the upper half of the slide and brush in the lower half of the slide, and then mix immediately. Fix immediately. Slides are fixed with 95% alcohol or spray fixative. 95% alcohol is the best thing. 80% is isopropanol, can also be used. And if we are taking the container with 95% ethanol, the material is usually fixed within 15 to 20 minutes. Liquid-based cytology is a monolayer slide preparation technology introduced to overcome shortcomings of conventional pap smear. It produces a sample fully representative of the material. Cells sediment to form a thin layer and excess fluid is discarded. Staining is an integral part of the process. SurePath and ThinPrep both are FDA approved. Plastic spatula cytobrush can be used to collect the LBC. Insert the spatula into the cervical canal and rotate 360 degree 5 times. And for the SurePath, you have to snap off the spatula, avoid touching the head of the device, drop into the liquid vial. LBC samples are collected by completely immersing the sampling device into the accompanying vial containing preservative fluid, whereby cells are preserved and fixed simultaneously. Advantages: better sensitivity, specificity, better fixation, making slide more representative, reducing mucus, blood, other debris, lowering the inadequate rate as all the cellular material removed the service is sent to the laboratory, increases laboratory throughput. Disadvantages: higher cost, change in routine collection, and not available in all the centers. Cytotechnologists and cytopathologists need to be trained. Sensitivity of a single pap smear for detection of cervical cancer is reported to be 52-60%, specificity is 95%. LBC sensitivity 82%, specificity is 97%. How do we report? The Bethesda system of reporting cervical cytology, it started in 1988, but it was upgraded in 2014. What has changed? The reporting of benign appearing endometrial cells is now recommended for women aged more than 40 years. It increases the predictive value of the category. When we report, first thing we write is specimen type, whether it is conventional pap smear or LBC, whether it is satisfactory for evaluation or unsatisfactory for evaluation. What do you mean by satisfactory for evaluation? Presence or absence of endocervical transformation zone component, at least 10 well-preserved endocervical or squamous metaplastic cells singly or in cluster. This is satisfactory for evaluation. Unsatisfactory, either there's no identification, broken slide, more than 75% of squamous cells obscured. So inadequate due to scanty squamous cell sampling, obscured by blood, obscured by inflammation, negative smear, and then interpretation. Even if it is negative for intraepithelial lesion or malignancy, you have to talk about Trichomonas vaginalis, where is a pear-shaped oval or round cyanophilic organisms ranging from 15 to 30 micron is seen. Budding yeast-like cells with hyphae of Candida, then Candida species you can see, then bacterial morphology consistent with the actinomyces species, herpes simplex infection, shift in flora, bacterial vaginosis, and even if we talk about non-neoplastic findings, this is reactive changes associated with inflammation, in reactive cellular changes associated with intrauterine contraceptive device, associated with radiation, associated again with radiation. Even if there's non-neoplastic cellular variation, there can be squamous metaplasia, there can be atrophic, as it is menopausal patients. Navicular cells of pregnancy. Again, navicular cells of pregnancy with coelocytes. There can be endometrial cells more than 40 years of age, out of range in the type of the period and month of the period. Endometrial cells, which is exfoliated endometrial cells in ball-like clusters. And then we come to the epithelial cell abnormalities. Squamous cell, there can be ascus, ASH, and you can see the ascus are typical squamous cells of undetermined significance. Again, ascus, ASH, or ascus with qualicytic-like cells, ASH, where you cannot rule out the high-grade lesion. You can see ASH here. Again, HPV associated with coelocytes. LCIL, you can see the nucleocytoplasmic ratio, more than 3 intermediate nuclei with slightly increased NC ratio, hypochromatic to normochromatic. This is low-grade lesion, and which can be associated with HPV infection or mild dysplasia or CIN1. This is high-grade lesion, where you can see the change in the nucleocytoplasmic ratio. High-grade lesion, again high-grade lesion. Squamous intraepithelial lesion, again high-grade squamous epithelial lesion with suspicions for invasion. Squamous cell carcinoma, these poorly differentiated keratinizing squamous cell carcinoma, and of course glandular cells, not otherwise specified. Other malignant neoplasm, ancillary testing, automated review, educational notes and suggestions. Cellular changes consistent with herpes simplex, coilocytes, where you can see enlarged hypochromatic nucleus and large, sharply demarcated perinuclear clear zone. And HPV associated changes, again, you can see HSIL, and we know LSIL regresses in 60%, persists in 30%, progresses in 10% to HSIL. HSIL regresses in 30%, persists in 60%, 10% to carcinoma. So squamous cell carcinoma, keratinizing, non-keratinizing, you have to mention. And now we come to the dual stain. P16, Ki67 dual staining cytology, and what are the implications? P16 is a tumor suppressor and Ki67 is a cellular marker for proliferation. The overexpression of P16 and expression of Ki67 under physiological situations are mutually exclusive and do not occur in the same cervical epithelial cells. So when we talk of dual staining, it tells us that the patient cells are doing in response to HPV infection, independent of their HPV genotype. It tells us whether or not the high-risk HPV E6, E7 are affecting a patient's tumor suppressive proteins. It tells us if a patient's cells are undergoing oncogenic transformation. It is kind of a immunohistochemistry which is done on cytological smears. It can be done only in the LBC collected samples, not in the conventional pap smear. P16, in addition, has been demonstrated to be superior to HPV molecular diagnostic in differentiated endometrial cancers with endocervical extension from endocervical adenocarcinomas. Ki67 studies have shown that Ki67 immunostaining correlates with degree of dysplasia and with the presence of HPV16 DNA more than with other high-risk HPV types. So what does it mean? Positive immunostaining for the tumor suppressor protein P16 is associated with the presence of mucosa or alpha subtypes of human papillomaviruses in cervical and genital squamous cell carcinoma. So the use of dual stain cytology is used for a triage test. Suppose the patient has HPV DNA positive for high risk, then dual staining can be used to triage that condition. Dual stain cytology is performed on liquid-based cytology and not on conventional P16, Ki67 expressed in cells that have been transformed by high-risk HPV due to actions of the HPV oncoprotein E7. P16 overexpression is shown in most cervical precancer lesions and cancers, but it is rarely observed in normal tissue. Co-expression of the anti-proliferative P16 protein and the proliferation marker Ki67 within the same cervical epithelial cells can be used as a surrogate marker of cell cycle deregulation mediated by HPV oncoprotein. So when we do by P16, it stains brown, and we do by Ki67, it stains red. You can see this is brown and this is red, and then both are present in one single smear. Then that means the cell has undergone changes due to the oncoprotein E6, E7 of HPV. So existing 2013 WHO guidelines for screening and treatment of precancerous lesions for the cervical cancer prevention, and we want to simplify the algorithm. Dual staining cytology can be used as triage test for cervical cancer prevention, both in the general population women and in women living with HIV. Because when HPV DNA high risk is positive, then there is a possibility of triaging either with cytology, LBC, or genotyping. But this P16 and Ki67 can be used as a surrogate marker for them. But most of the centers are still not adopted it because there is a problem of validation. And of course, the technology is not available in all the centers. WHO suggests that using samples taken by the healthcare worker may be used as primary screening test either with or without triage to prevent cervical cancer in general population of women with regular screening every 5 years. This can be done with HPV DNA testing. In a screen, triage, and treat approach using NAT for HPV detection as the primary screening test among the general population, WHO suggests using partial genotyping, colposcopy via cytology to triage women after a positive HPV test. And now this dual screening can be used as a to triage these high-risk patients. And of course, in screen triage and treat approach using HPV DNA detection as the primary screening test among women living with HIV, WHO suggests using partial genotyping, colposcopy via cytology to triage women after a positive HPV DNA test. What is the role of doing this? To conclude, cytology remains an important tool for screening for cervical cancer. LBC has advantages, yet in some of the centers, conventional pap smear still remains an important tool in the screening process. Addition of dual stain cytology has added a new era in triaging for cervical cancer. Thank you for your patient listening.
Thank you very much, Dr. Mala Srivastav. Excellent talk. And in 15 minutes, you managed to do justice to so many different aspects, including the most recent advances, which many of us may not be aware. Thank you very much for your excellent deliberations. If there are any questions from the audience, you may put them in the chat box and the speaker will respond to them in the chat box itself. Since we are running about 15 minutes behind time, I would suggest we move on to the next session. And it's my pleasure to introduce Dr. Asha Jain. Dr. Asha Jain is the past president of the Raipur OBGYN Society. She's the medical director of SMSA Hospital in Raipur, and she's currently the president of the Raipur Menopause Society as well. Recently elected as a FOXI chairperson, and she's going to be speaking to us on HPV. Over to Dr. Asha Jain.
Thank you so much, Prateek sir. And I would like to speak on HPV and cervical cancer. Thank you, Dr. Priya, for having me. And thank you, Prateek sir, for that really informative introduction. The topic that I have today is extremely vast. It's just HPV and cervical cancer, which is, I think, all of the pathophysiology and treatment and prevention put into one. But I shall be dealing with a positive test more than anything else. So, Shri Ganeshaya Namah, this is my grandson who has just
Congratulations,
been born.
Asha.
Thank you.
Yes, for becoming grandmother.
Congratulations, Dr. Asha.
Thank you. Thank you so much. So today I brought him in front of the world because his mother was having a bad time, but now they are both okay. So as we know, cervical cancer is caused, HPV is a necessary cause of cervical cancer, and there are more than 200 HPV types. Around 40 will infect the genital tract, and 14 are carcinogenic. Why HPV testing? We have heard about LBC in great detail and all the things that it can do. Now I'm going to talk why HPV. HPV is the most sensitive and has the highest negative predictive value. HPV test alone or in conjunction with cytology allows lengthening of the interval of screening and deferral of colposcopy for low-risk results. So you are not overburdened by colposcopy cases, having the large number population that we have. What is the WHO guideline for screening and treatment? The recommendation is that HPV DNA detection is as the primary screening test rather than VIA or cytology in screening and treatment among both general population and women living with HIV. And this is a strong recommendation. What are the guidelines for screening? Start at 30 years. When to stop? When you're doing it with HPV, 50 years after 2 consecutive negatives, you can screen once in 5 to 10 years. If she's HIV positive, 3 to 5 years. And if HPV is not operational, then you can continue with cytology or VIA. So what does FOXI recommend? If there is a good resource setting, then preferred is HPV DNA testing. Acceptable is cytology or VIA. And in a low resource setting, if an HPV test is affordable, then that is the first option. And if it is not available, then visual inspection with acetic acid, and the age group is 30 to 65 years. The use of VIA is very limited in postmenopausal women. So these recommendations have been dealt with by my previous speaker. What does the ACS guidelines say? Less than 25 years, no screening. Ages 25 to 65, start at 25 years, and a primary HPV test alone every 5 years is preferred. You have to use an FDA-approved HPV test for primary screening. Co-testing every 5 years or cytology alone every 3 years are acceptable. Co-testing or cytology testing alone are acceptable where access to HPV testing is limited. If she is aged more than 65 years, if there is adequate negative screening, then you can discontinue. But if there is no screening done before, then you can go ahead and do the screening once. Adequate negative prior screening is currently defined as 2 negative primary HPV tests or 2 negative co-tests or 3 negative cytology in 10 years, with the most recent test occurring within the past 3 to 5 years. After hysterectomy, if an individual is without a cervix and without a history of CIN2, then they don't need screening. HPV vaccinated have to be screened the same way as non-HPV. Now, what about the HPV test that you have? There are 254 distinct HPV assays and 425 assay variants available in 2020. More than 90% of these have not undergone analytical, clinical, regulatory evaluation. They have not been evaluated by stringent clinical validation protocol. And that is why it is extremely important that you need to screen only by the FDA-approved tests. Now, which are these tests? These are available on the WHO website. HPV DNA signal amplification methods, the hybrid capture, the Cervista, and CARE HPV. PCR-based, COBAS, Abbott real-time high-risk, PRETECT, and mRNA-based Aptima. These are the 3 basic types and the 7 validated tests that you have. HPV mRNA and HPV DNA tests without FDA approval for primary screening alone should only be used as co-test with cytology. So you do it HPV and cytology together, and as Dr. Mala ma'am just explained, it can be done with the same sample. So this is the hybrid capture 2, the mRNA, the COBAS, Aptima, and the BD Oncology HPV assay. And if you see this, there are only a few tests that are allowed. The hybrid capture is for ASCUS triage and for test of cure. The mRNA is also for ASCUS triage and for test of cure. COBAS can be used for primary testing. Aptima for co-testing and ASCUS triage, and BD Oncology HPV assay is for primary testing and ASCUS triage. So if you go, which one are you going to do? Primary HPV screening for patients 25 years or older, COBAS HPV, Roche, Oncology HPV, these are the only 2 tests that are available to you. And out of that, in India, for primary testing alone, only COBAS is there. So now you have done the test and you have a positive report. What are you going to do? In a screen and treat approach, using an HPV DNA detection as the primary screening test, WHO suggests treating women who test positive for HPV among general population of women. So if she is HPV positive, treat. Then there is a screen triage and treat where you do an HPV DNA and then use partial genotyping or colposcopy or VIA or cytology to triage these women. And if the second test is also positive, then you go ahead and treat. So this is the flow chart And where you see if it's negative, you are going to put her on screening 5 to 10 years. If it's positive, then see if it can have ablative treatment. If ablative treatment is possible, go ahead and do it. Not eligible, go for LETs. If it's suspected cancer, you have to treat accordingly. And if you see nothing on triage, then you just wait. Screen triage with genotype and treat. It's basically the same. Whether you do a cytology, whether you do a colposcopy, whether you do a genotyping, that you do the second test. If it is positive, go ahead and treat. If it is capable of being ablated, ablate. If not, do a LETs. So LETs is a large loop excision that will be dealt with later. Now, if you have to screen triage with VIA, again, you go to the same thing. Screen triage with colposcopy, you've done an HPV. If it is negative, then you're going to call her after 5 to 10 years. But if it is positive, then go ahead and do a colposcopy. And Dr. Priya explained you the sweet score. According to the scoring, according to your suspicion, you can go ahead and treat that patient. So you do not treat a positive HPV test, that you have to understand. An HPV test has to be followed by another test, which if positive, then it requires treatment. What about cytology? Again, if it's a co-test, you have the report. If the cytology is negative, you can repeat the HPV after 2 years. And if she's HIV positive, repeat in 1 year. If it's negative, put her back to the routine screening. If it's positive, if it's ascus or worse, do a colposcopy and then treat as per the colposcopy. What does Foxy say? Screen and treat protocol. Primary screening by VIA or by HPV. Now, if we are dealing with HPV right now, if it is positive, go ahead and do a VIA. If it is positive, ablative if needed, or excisional if that cannot be done, follow in 1 year with HPV DNA. If negative, then you can rescreen in 5 to 10 years. But a positive HPV test, do a repeat test after 1 year and see that it turns negative before she goes back to the regular protocol. Primary high-risk HPV DNA testing, if it is negative, rescreen after 5 to 10 years. Positive, do a genotyping. If it is 16 or 18, go ahead, do a colposcopy and treat. If it is something else, you can wait and repeat the test after a couple of years. Primary screening with HPV, VIA positive, ablative treatment can be done if the lesion is eligible for an ablative method, or otherwise you go ahead and do an excisional method. If HPV DNA is negative, then routine screening will be after 5 to 10 years, as per whatever your protocol. Foxy has the screen and triage and treat. Basically, I've already explained what are the principles. That you do another test. If that is positive, treat. If the lesion is confined to the cervix, it's all ectocervical. If it involves less than 75%, then go ahead and do an ablative procedure, or otherwise do an excisional procedure. The 2019 ASCCP update is that the persistent HPV infection is necessary for developing precancer and cancer. So just a positive test does not mean that you have to treat her. Management is risk-based and not result-based. HPV test, then do a reflex cytology, combination of current results and past history. Decide the immediate and remote risk of CIN3. According to this risk, either the patient goes for expedited treatment, immediate colposcopy, surveillance, or return to screening. 2019 ASCCP guideline chose CIN3 instead of CIN2 as surrogate for cancer risk of management guidelines. Why? Because CIN3 is pathologically more reproducible. HPV type distribution in CIN3 plus lesions more closely approximates that of cervical cancer than the larger range of types found in CIN2. And CIN2 has appreciable regression rates, as Mala ma'am said. So what are the recommendations for primary testing? All HPV positive on primary screening tests, regardless of genotype, should have an additional reflex triage testing from the same lab specimen. Then we decide what is the CIN3 risk, whether it is greater or less than 4%. If it is greater or equal to 4%, then look at immediate CIN3 risk and find the correct combination. So when are you going to go for expedited treatment? When it is 60 to 100%, colposcopy with treatment 25 to 59, colposcopy 4 to 24%. If it is not there, then return in 1 year, return in 3 years, or return in 5 years, depending on the risk. So how is this risk calculated? HPV positive with HSIL in unscreened, unless she is pregnant or less than 25 years or has fertility issues. So this is 60 to 100%. For expedited with colposcopy, acceptable 25 to 59%, she's 25 or older, HPV negative HSIL, HPV positive with ASCET cytology, HPV positive with abnormal glandular cells, and HPV positive with HSIL cytology. So this is in the intermediate range, and then go only for colposcopy, which is HPV positive ASCUS or LSIL in the general population. Look at the 5-year CIN3 plus risk and find the surveillance interval. If the patient is for surveillance, if she is HPV positive ASCUS or LSIL after a negative HPV test or co-test, then within 5 years or colposcopy examination less than CIN2 within the past 2 years, then she can go for a surveillance, HPV positive with a negative cytology, HPV negative but with LSIL, or after colposcopic biopsies, she is found to be CIN1, preceded by a low-grade co-test, HPV positive LSIL or ASCUS. In that case, she is to return in 1 year. When is she going to return in 3 years? When there is a low-grade co-test, negative cytology, and HPV negative on ASCUS. Negative HPV-based screening in general population, then she returns in 5 years. So this is the basic chart, what treatment.
Ma'am, sorry to interrupt you. Your time is up, ma'am.
Yeah, finishing. So if there is a prior negative screen, you would proceed and go ahead and do a colposcopy. This is the very basic. Persistent HPV is a predictor for CIN3. So you go ahead and treat her accordingly if she has persistence. You have seen these images. Now I go to my last slide, and that is know the test that you have to do for HPV, know the lab, whether it is validated, what is your target population, decide which guideline you're going to follow, adhere to that guideline, and always link your HPV testing to treatment. Without that, it is absolutely no use. These are my acknowledgements. Dr. Rimpi Singla helped me with the slides. Thank you. Thank you very much. Questions are welcome in the chat box.
Thank you, Dr. Asha Jain, for comprehensively covering all the different clinical scenarios. Unfortunately, for none of today's talks, it's possible to do justice and finish in just 15 minutes. But then within the scope and confines of this particular framework of the ICOG certificate courses, we don't get more than 15 minutes. Questions, there are plenty in the chat box. I would request you to please address them if possible. And we'll move on to the next speaker. We have the distinct privilege of having with us Dr. Bharti Abhyankar. She is a vice president of AMOGS, and she has done extensive work in the field of colposcopy, cervical cancer, and she has contributed various chapters in books. Thank you very much for joining us, ma'am. And over to you for speaking on your chosen topic, which is VIA and VIAM.
Yeah, thank you so much, Dr. Pratik, for nice introduction, and thank you, Dr. Priya, for giving me this opportunity. So we have up till now heard about various screening modalities. Just I will share my screen, which require various things like cytology. You need brush, you need container. For HPV, you need a very what I can say accredited lab. You have to send the samples. But now what I'm going to tell about is a very simple method of screening for the cervical cancer, and this is what is called as a VIA and VM is the topic given to me. Okay. I'm audible and visible, I hope.
Yes, ma'am, please go ahead.
Okay, so VIA is a short form of visual inspection with acetic acid, and VM is visual inspection with acetic acid using magnification. So in short, I'm going to tell you what exactly it is and how you should go for it. So we all know there are three ways of screening. First is a primary prevention. Second is a screening. I mean for prevention of cervical cancer, primary prevention, secondary prevention, and tertiary prevention. So screening is a modality of secondary prevention of cervical cancer. Why it was there? Because there were difficulties in implementing the cytology-based screening in low resource settings mainly. As I have explained earlier, need of brush and container, everything. So they searched out for a low-tech test such as VIA, VE, and VM in the early detection of cervical neoplasias, which is very helpful. So in visual methods, we have unaided method, that is you just put a speculum and visualize the cervix. Then we have a visual inspection with acetic acid. We have visual inspection using magnification, and then we have visual inspection using leukocytin. We also have colposcopy, gynocular, cervicography, videography, speculoscopy as a visual methods. The advantages of visual methods are but obvious. They are less expensive, useful in developing countries like ours. There is very high negative predictive value, and this point is very important. You can apply, see, and treat policy very easily in via positive cases. So it's very helpful in rural areas where most of the population of India resides. And even a paramedical person, if he's trained, he or she is trained properly, can do it via testing in a primary health centers also. So the principle behind this, we have learned in colposcopy that we apply acetic acid. So what this acetic acid does, it coagulates the nuclear protein in the cell and makes it white and opaque. It's very simple. So normal cells are having a less nuclear protein as compared to abnormal cells. So these abnormal cells, they become more white because the nuclear content is high. And when you apply acetic acid, it takes up the acid and becomes white, and the light cannot pass through it. And that's why it becomes an opaque. So we label it as a VIA positive. So the strengths of VIA are, it's very simple, easy to learn, minimally dependent upon the infrastructure. The cost is low. You can apply screen and treat protocol. It can be performed by paramedics, and the results are immediate. You don't have to wait for the labs to give you the report. The results are comparable to PAP and HPV. That is very important. The procedure is very simple. You have to explain the patient, take her consent, give her lithotomy position, insert cuspo speculum, which is a very difficult step for the newcomers because they don't do the per speculum examination. So start doing per speculum examination. Insert cuspo speculum and then apply freshly prepared acetic acid completely for 1 minute. Don't do just apply and see the results. No, you have to wait for 1 minute and then try to define, as Priya had nicely said, try to define the squamocolumnar original view and identify the transformation zone. And then observe the changes that are occurring in TZ. Acetic acid, usually the commercially available is 100% acetic acid. So we have to use 5%. So remember it. The preparation is very easy. You can add 95 ml of distilled water in 5 ml of glacial acetic acid and prepare it daily throughout the remaining at the end of the day. And once you have applied acetic acid for 1 minute, then the results are interpreted as via negative when there is no acetowhite lesion, or sometimes very faint acetowhite lesion like a polyp, endocervical polyp. If there is cervicitis, chronic inflammation, presence of nephrothesis, they may look acetowhite, but they are via negative. What are via positive? When you see any sharp, distinct, well-defined acetowhite lesion with or without raised margins, the lesion is touching the squamocolumnar junction, it is near the external os or maybe circumferential, and usually these lesions, they are termed as positive via. And if you are suspicious of invasion, naturally you see an ulcerative cauliflower-like growth, which we don't want to see, and that's why we are doing the screen. So once it's an aceto-white area, then what you should observe, you must see the intensity of the white color of aceto-white lesion, how fast it comes, and how long it persists. If it is a shiny white, cloudy white, pale white, or dull white. Again, see the borders and demarcation of the white lesion, whether the borders are very clear and distinct, they are sharp or they are indistinct and diffuse, whether they are raised or flat margins, or whether the margins are regular or irregular. Then you look for the uniformity, whether the white color is uniformly distributed or the intensity of the whiteness varies in the same lesion. You look now for the location of the lesion, whether the lesion is in the transformation zone or it is away from the transformation zone, whether the lesion is abutting the squamocolumnar junction, is it extending into the endocervical canal, or it is occupying the part of the transformation zone, or it is occupying the entire ectocervix or the entire transformation zone. And then you see the size of the lesion. Usually the size of the lesion is taken into consideration as occupying in 1 quadrant, 2 quadrant, or you can say 25%, 25 to 50% of the cervix, or more 50 to 75% of the cervix is occupied by the lesion. So you have to consider via positive when the lesion appears very fast and lasts for 1 to 2 minutes. If the lesion appears late and disappears, it's obviously via negative. If the color intensity, shiny, cloudy white, more dense, thick and opaque, it's via positive. But if it's pale and dull white, translucent, then it is via negative. If the borders are well demarcated, regular, raised from surrounding epithelium, it's via positive. And if it's a patchy, ill-defined, diffused margins, very faint margins, then you can say that it's a via negative. And very important is location of the lesion. The restricted, if the lesion is restricted to TZ, then it's definitely a via positive lesion. And if it is not, then it is via negatives. We call them sometimes as a satellite lesions when they are not in the transformation zone. These charts, these quick clinical referral charts, they are available on the net, and you can download and keep it in your consulting room or whenever you are doing the screening, because they are very handy, they are very useful. Here you can see the acetowhite area, then some polyps, some mucus plug looking like an acetowhite area, then this is an Abothian cyst, and this is an endocervical polyp. All these are via negative. But what happens in via positive? Definitely you are able to see an acetowhite lesion. Here also you can see a well-defined acetowhite lesion and one lesion extending into the cervical canal. Here you can see an acetowhite lesion occupying entire 360 degrees of the cervix. Here the lesion is on the posterior lip. Here the lesion on anterior extending in canal, as well as the lesion is on the posterior lip. And obviously you cannot miss this high-grade lesion by this simple test of visual inspection with acetic acid. And these pictures, they show the suspicious growth. As I said, it's very promising to do via. There are certain limitations. Many false positive results are seen. As I said, the Nabothian cyst. In the initial phase, you may see a acetowhite area is there, but that is a via negative. So over-treatment can be can happen in this see and treat protocol. Training quality measures are definitely required because when we teach the paramedical staff, they don't know what columnar epithelium, what squamous epithelium, and what transformation zone is. So training is very much needed. And in postmenopausal women, or nowadays when the C-section rates are very high, where you cannot define the TZ properly, or it is a type 3 TZ, which means it is entirely in the endocervical canal, then you cannot do this visual inspection with acetic acid test. And some more evidence are needed for a modeling study, but we can say if a woman undergoes VIA test at the age of 35, the lifetime risk of cancer is reduced from 25 to 36%. And if you advise her to do one more test after 5 years, then again the risk is reduced by further 40%. So if only twice she undergoes this VIA testing, then definitely we are able to reach to the goal of WHO of eliminating or reducing the rate of cervical cancer. Now coming to the VIA, that is visual inspection with acetic acid after magnification. Because what happens when you are doing VIA, you know how the cervix looks with cusco speculum only. It's very difficult to identify. It's very difficult to define the acetobite area. In that case, you have to use some magnification. And I personally do it in my clinic and it's very promising. So several reports and several studies, they indicate a significantly low specificity for VIA when compared to cytology. Then simple magnifying devices, these are nothing special. This is not a colposcope. This is not a gynocular. This is not a mobile colposcope, but only a simple magnifying glass, which gives a magnification of 2 to 4 times. They have been used to visualize the cervix after application of acetic acid. And this approach was found to be improving the specificity of VIA without compromising sensitivity. So in a hospital-based cross-sectional study in Delhi, our own study, they involved 406 women, and Parashri and co-workers have done this study, and they reported a sensitivity of 88.1 and specificity of 67.5% for VIA using a 2.5 times magnification device for reporting. So it's of interest to note that the specificity falls within the range observed for VIA in other studies. Incidentally, no difference in test characteristics between VIA and VIAM were observed in a reported cross-sectional study in South Africa. So entirely the VIAM was outdated. But my personal experience says that I have done this study, analysis of screening modalities for cervical cancer in my private setup. Usually we do screening, we take liquid-based cytology or HPV depending upon the affordability of the patient. I studied patients during 1 year, and the method I applied was again a VIA testing, but I visualized the cervix with the help of magnifying lens having LED bulbs on it. And I was very happy. It reduced my colposcopy rates tremendously because I was able to see all the acetobite areas in the OPD itself. Again, the results were noted as positive, negative, and the findings were tabulated. And maximum screening happened in 35 to 45 age group when we convince the patient. It's very simple. I'm just observing your cervix. We don't need to tell them that it's going to take 15 minutes, 20 minutes, and so on. And so this age group was very much appreciable to do this or was eager to do this test. And 54.6% were para 2, 25.8 were para 3. This is not very important. What was important is my pleasure in doing the test. I was happy doing the test, and the results were also very good. So in my analysis, cytology was abnormal in 7.2%, VIA was positive in 5.5%, and HPV was positive in 4.76%. Of course, the tests of HPV done were less as compared to cytology and VIA, but initially I used to do only VIA testing, but gradually I shifted to co-testing depending upon the affordability of the patient, whether she's affording. I used to do a co-testing with VIA plus HPV, or via plus liquid-based cytology. As Dr. Asha Jain told in her talk, if the patient is HPV positive, you have used HPV as a primary screening modality and HPV is positive, then what they are advising is you triage it with a via. So why not do via initially and then go for the test? Where the test like HPV and NBC are not available, definitely you can go for via. Or I always say to my students, whenever you are starting with the colposcopy, you want to learn colposcopy, you start doing via so that you can see actually what acetovyte area or acetovyte positive and acetovyte negative areas are. So via usually is followed by VILI, that is visual inspection with Lugol's iodine. Now again, the principle, iodine is glycophilic. So the cells which contain glycogen, they will take up the iodine and will stain mahogany brown. Columnar cells, they lack glycogen, so they don't stain with Lugol's iodine. But squamous, normal squamous epithelial cells are rich in glycogen and they take up the iodine and they stain mahogany brown. But if the abnormal cells or acetovyte area are there or abnormality is there, those abnormal cells will lack glycogen and they won't take up the Lugol's iodine. So again, the results are same as via, that is negative, positive, and suspicious of invasion. It appears to offer improved accuracy and reproducibility over via alone. So you cannot do VILI alone. The VILI should always be preceded by via. So usually what I call it as a second opinion. When you have seen a acetovyte area and do VILI, and if that area remains unstained, then you are 100% sure that this is an abnormal area. It also helps you to take the biopsy from that area. Again, the VILI negative.
Sorry to interrupt, ma'am. Could you
Yeah.
please wind up?
Okay, it's fine. This is almost last
I'm
slide.
sorry to interrupt, ma'am. It's time up,
Yeah.
ma'am.
So this is again the same charts are available, so you can do. And just 1 minute, the results of via are comparable to PAP and HPV. This is very important slide. So the negative predictive value of via you can compare with PAP and HPV. That's all. So thank you very much for giving me the opportunity. Only one thing I want all of you to tell, block your dates 18 to 20th April 25, because we are having a great national conference of IACCP in Kolhapur, Maharashtra at Hotel Sayaji from 18th to 20th April. We are going to clear all your doubts and dilemmas regarding the colposcopy and cervical pathology. So thank you very much for giving me the opportunity. Thank you.
Thank you very much, Dr. Bharti Abhyankar, for a comprehensive talk covering various different aspects and your own unique personal experiences. That was what we really appreciated. You had 3 excellent talks in this session. Dr. Mala Srivastav, who is a well-known oncology expert, Dr. Asha Jain gave us very beautiful flowcharts and illustrated how we go about practically approaching these women. And Dr. Bharti Abhyankar, of course, spoke excellently, drawing on her own immense experience and knowledge. I'd like to express my gratitude to the conveners of the course, Dr. Priya Ganesh Kumar, who is here today, Dr. Sarita Shamsundar, and Dr. Archana Chauhan. Thank you very much for having us here. Dr. Bharti Maheshwari, I think, had to disconnect after some time because she was traveling. But on behalf of Dr. Bharti Maheshwari and myself, Dr. Pratik Tambe, thank you very much, ICOG, for this opportunity. And thank you, Dr. Priya Ganesh Kumar, for having us here. I'll hand
Thank
you
you very
back
much,
to
Dr.
Dr. Janani, who is doing an excellent job today.
Thank you, Dr. Pratik. And really, after the 2 sessions, it has been a wonderful day. Going ahead, we are going to have now wonderful case-based discussions. And here we are getting, we are also going to get little cancer cases also. So be tuned. And over to you, Dr. Rimpi. Dr. Janani, you can, call up the
Yes,
moderator.
ma'am. So thank you, chairpersons and speaker for the day. And we'll start the session 3 of the day. This will be a guest-based panel discussion, and I welcome all the moderators and the panelists of the day. The first moderator will be Dr. Rimpi Singla. She is associate professor of PJ Chandigarh, and She she has organized many workshops, and she has been a publication of 28 and plus 6 chapters in the books. And the next panelist of the day will be Sika Sit ma'am. She is a professor and head of the Department of Obs and Gynae at AIMS Gorakhpur. And ma'am has achieved a lot, and ma'am has published 60 publications, and she has been an assistant editor of journal SAFOC. And over to you, ma'am. And another panelist. Famida ma'am is not able to join as she is on emergency. Next panelist. Bharati ma'am is a consultant at Porva Hospital since 36 years, and she has passed international exam on colposcopy and cervical pathology. And also she is a vice president of AMOX to 2024 to 26. And over to you, ma'am. Next.
Reena is also not
Reena
there
ma'am
because of her health problem.
Reena ma'am is also not there. Next.
Dr. Rashmi Bagga is there. Yeah.
So I welcome Dr. Rashmi Baha ma'am. She is a professor of Department of Ops and Gynae, PJ Chandigarh, and she has published over 200 in national and international journals. And she's a president of Obstetrics and Gynecology Society of Northern India. And over to you, ma'am.
Thank you. Thank you.
So I welcome all the moderators and the panelists of the lesson. And also I request the moderators and the panelists of the day to stick on to time, as it is a request from the audience. Thank you, ma'am. Over
Sure.
to you all, ma'am.
Good evening, everyone, and special thanks to Priya ma'am for giving me this opportunity to carry forward this very important topic. And I hope that whatever we have learned over the day, and it is reinforced through these cases. So moving forward, these are the basic guidelines which I want everyone should have and should refer to them frequently for screening and management. Earlier, I wanted to cover about screening, but it has been extensively covered. So for the management part of cervical cancer, once we have invasive disease, just briefly, I wanted to highlight that the FIGO has recently updated the staging, whereby it's stage 1 is confined to cervix and 1A1 is the microinvasive, and when the depth is invasion is less than 3 millimeter, and 1B is the macroscopic disease, and depending upon the size, whether it is less than 2 centimeter, more than 2 centimeter, further categorization have been done. And when it is beyond the uterus, it is becomes stage 2A. And when it is stage 2, and when it involves a parametrium, stage 2B. And when it goes beyond the lower third of vagina and the parametrium up to the pelvic wall, or if it involves the lymph nodes, then it goes to stage 3. If it involves the bladder, bowel, and spread to distant organs, it becomes stage 4. So briefly summarizing this management chart, it is looking extensive, but understand this thing that in early stages of cancer, we are having surgical management in the form of conization, radical trachelectomy for fertility preservation options, and simple hysterectomy to radical hysterectomy depending upon the stage. But after stage 1B3, everywhere it is a platinum-based concurrent chemoradiation which has been recommended, and the extent of radiation depends upon the nodal involvement, whether you want to cover the para-aortics or not. So basically, this is the main highlight of the management, that in the two therapies should not be combined. In advanced stage, the radiation therapy is the management of choice. And this is just summarizing, and this is I picked up from the GCPR guideline. It is beautifully described the 3 types of hysterectomy. In the early stage 1A1 and stage 1A2, we can go for the extrafacial hysterectomy, and in the subsequent stages up to 1B2, modified and radical hysterectomy can be done. So this is the reference for my subsequent slides. So quickly moving on to the clinical scenario first. She's a 32 years old. She comes first time for the routine screening, and you did the HPV DNA testing. She's positive for high risk HPV DNA. So my first question goes to Dr. Shika. What will you like to advise her? Would you treat this HPV positive or observe or do any further testing?
I think once there is a HPV positive, and that is also named as HR, high risk HPV positive, we should go for colposcopy to identify actually the lesion is there or not. And if we find out something on colposcopy, we should go guided biopsy and then finally decide the treatment based on the colposcopic findings or the biopsy results.
Anybody else wants to discuss any other approach? Shikha ma'am wants to go for colposcopy.
We can do a co-testing by via simple test if colposcopy is not available, and then we can go for see and treat also. Or if the patient is from educated class, from affording class, she can understand whatever you are telling to her or explaining to her, she can come for the follow-up definitely. Then we can do depending upon your scenario. So definitely co-testing with via can be done.
Fine. Guidelines are one thing, but I really appreciate that we have to look at the patient's background and then offer her further treatment. So we have, according to our FOXY GCPR guidelines, we have two options to offer. One is screen and treat straight away. If we understand the patient may not come back for subsequent visits, or we can have screen, triage, and treat. And in the FOXY guidelines, we have got genotyping, colposcopy, as Dr. Shikha said, and cytology. For this particular patient, we did cytology. And her result was that cytology result came out to be ascus. So my next question goes to Rashmi ma'am, that now she has HPV DNA positive, high risk DNA positive, she has ascus. Now what will be the next strategy? We'll observe or treat her or do colposcopy?
Colposcopy, because the threshold risk of CIN3 plus crosses 4% when you have HPV positive plus ascus. So
fine.
Colposcopy
So,
and decide.
yeah. According to ASCCP also, it crosses the threshold for colposcopy, and in our GCPR guideline also, when we have cytology triage positive, ascus or more, she qualifies for colposcopy plus minus biopsy. Fine, we did the ASCCP guideline. This is highlighting the same thing. We did the colposcopy. We found a high-grade lesion, and biopsy showed CIN2. We did the ECC also, but it was a normal ECC finding. So what should be the further strategy for a CIN2 in the background of this thing, ascus and HPV positive? Dr. Shikha or Dr. Rashmi, anyone you can take up?
I think because it is a high risk HPV positive and an extensive lesion, which is clearly aceto-white with sharp margins, good scoring on the colposcopy, and biopsy also suggests CIN2, we should go for an excisional treatment of this particular lesion with taking all the transformation zone and sending it for the histopathological diagnosis.
Fine.
Excision is the treatment because it is HPV positive, and then it is whatever the colposcopy or the via kind of a thing, aceto-whiteness is there. Whether on colposcopy or just on a via, whatever has been done. So excisional treatment should be the choice for her.
And ma'am, what are the criteria if for ablation? Priya ma'am, can we do ablation in this case?
Just show the, yeah. In this case, see, there is an extension into the endocervix. So definitely it will not go in for an ablation. It has to go for excisional methods only. So that's exactly how what Shikha
So
said.
yes, if you look at the criteria, it is showing like it's kind of type 2 transmission zone also, and the lesion is extending into the endocervical canal. So for this particular patient, LEAP would be a better option than cryo or ablation. So what about further follow-up? We did LEAP excision, margins were free. And what should be the further follow-up? When would you like to see her next? And what test will you do? Rashmi ma'am, you can take up this question, ma'am.
Yeah, so I would like to see her at 6 months. And here I would like to do a co-test for her, HPV with cytology. And if that is negative, then annual two more. And then if they're all fine, then she can go back to routine screening. But these three rapidly placed tests, I will call it as a test of cure.
Great. Bharti ma'am, anything anybody wants to add in this case from their experience, or we should move on to the next case, ma'am?
Yeah, one more thing, Rimpi. In fact, I wanted you to others to also answer. After the co-test is negative, test of cure is negative 3 times, does she go back to the 5-yearly follow-up or does she become 3-yearly follow-up? Because the ASCCP guidelines always places them in a 3-yearly, not 5-yearly. which is
3
different from
yearly.
routine screening.
I
And
Yeah.
for further 20 years.
3
And
years
also for
with
further 20 years
HPV-based
from the
test.
time of treatment.
Just to save the time, I omitted those slides. ACCP says that you have to go on with the surveillance for 3 yearly till the age of 65 years or 25 years of surveillance. And at the age of 65 years, if the patient is healthy, you can even continue the screening after that. So
Yeah,
surveillance.
so we should not say routine surveillance because
It is
and the
surveillance. It is
surveillance
the
always
post-
has to be HPV-based test surveillance.
Yes. There is a difference between the screening and there's a difference between the screening and the surveillance. Now the
Right.
patient had CIN2, she had HPV positive. So this is surveillance, not the routine screening protocol.
Right.
Priya
So
ma'am
here
wanted
when we
to
are
add-
using HPV, it goes 3 yearly if it is a surveillance post-treatment. And if we are using cytology-based test of cure and surveillance, then actually it goes yearly.
True.
Not 20. So what we do is, so that is the reason why HPV should be taken is at least you have got a lengthier duration. You can also use a co-test. Another thing which I wanted to add, Rimpi, was whenever we do a LETS, we have to also look into the margins. So that's one thing which our audience also should know about. Whether
Yes,
the
ma'am.
margins are free or not.
Yeah, the margins were negative in this case. And what ma'am, in case the margin is positive, then what will you guide them?
If the margin is positive, I feel ki we should redo the things because it is a high risk HPV based test. But of course, in some of the instances, if the patient is understandable, she can be observed with annual HPV based surveillance. Suggesting because sleep we have done
We have done.
the margin also although came out to be positive, but it was the HPV which is the positive point.
Absolutely.
So if we can go for HPV based annual surveillance, we can observe her for some time. Otherwise, it is always better to go for an redoing some more bit of leap.
Yes, ma'am. All the options are there, and when one Foxy has already taken care of Indian women, and it has written if the re-excision is not possible, or if you understand that the women is not going to follow up, then in the setting of CIN2, if the previous lesion was also high-grade cytology, then you can even go for hysterectomy in these cases. If the cytology is also high-grade and the histopathology of CIN2 is there, in those cases, if you don't expect her to follow up. So
Yeah.
I move on to the next case by permission of all my panelists. Should we move on, ma'am?
Yes.
She's a 35 years old. She's para 2, two living issues. She underwent screening by cytology and it shows Ask H. So she was quite panicked. She comes to you, ki, madam, please do my hysterectomy. I have got cancer. So what will you advise her, Bharti ma'am? This is for you. She's Ask H, 35 years old, para 2. Rashmi ma'am, you can take up this.
So as sketch is colposcopy. I mean, all these risks are above 4%. I think it is probably maybe 20, but you can correct me. And I will proceed for immediate colposcopy and colposcopic guided biopsy. I mean, I will really look for the source of the high-grade cells in my colposcopic biopsy and hope to find them.
Yes, both the guidelines, if we talk about ASCCP or we talk about our FOXY guidelines, both of them recommend if it is more than LCIL, then she needs to be treated. And yes, here we have already, ma'am has addressed this. So the colposcopy has to be done in those cases and further treatment plus minus biopsy depending upon your this lesion. And upfront colposcopy is required, but we don't need to do her HPV testing or any other triaging if she is having Ask H on cytology, because if whatever it is, the risk of cancer, having a cancer is same, almost same, whether she is HPV positive or negative, if she has Ask H cytology. So this is her colposcopy finding. I hope it is clear on the screen. Mine is a little bit hazy. So this is the colposcopy finding. If you can see, there is mosaic
is a
here,
dense acid
and it was coarse mosaic, and there is aceto whitening here, and the lesion is going into the canal, and there is some amount of aceto whitening here also. We did a biopsy from this region. It turned out to be high-grade squamous intraepithelial lesion. So my next question to Bharti ma'am. Now she is a family completed 35 years age and Ask H. Now she has got biopsy showing HSIL. So what will you do for her now? Would you consider hysterectomy or some excision or ablation? I guess Bharti ma'am is disconnected. Priya ma'am, would you take up this one?
Yeah. So now again, this case now here, if you look at the lesion, that's going, you have a multiple this thing, and then is also going in endocervical. Definitely will not think of taking an ablation. The criteria for the ablations are very, very simple, that it has to be a TZ1. If it is a TZ2, then the whole SCJ should be completely visible.
Yes.
And it should not have any suspicious of a cancer. It should not have any high grade this thing. So here the suite definitely is going to come to around 8 to 9. You can't even think about ablation. And another criteria for ablation is you should not have an endocervical, extension to it. So
Right.
here definitely
And this
ablation,
one is
excision. Cannot think
extended.
about hysterectomy and all. Why think about hysterectomy?
Great, ma'am.
When you can do a very good this thing, excision.
Yes, hysterectomy is unacceptable and excision is preferable. And as Priya ma'am very rightly pointed out, this lesion is not amenable to ablation. So this is same in our GCPR guideline. If it is amenable, you can go for ablation, otherwise excision by LEAP. So she underwent LEAP. Now histology came out to be CIN2. We have already discussed the importance of margin. So I'll skip this. Our that what we have 31 minutes more.
Yes.
Yeah,
Okay.
you can go ahead. Yeah.
CIN2. So we want to look at the margins. Shikha ma'am, again, please summarize this thing.
I think it is always better to look for the margins. But yes, if we are following with HPB based assays, then it's not that must means we can go ahead even without checking the margins. But always better to have a margin, I feel. And if margins are positive, we have to be more assertive for annual, and we're keeping the patient for observation, then annual HPV based surveillance is must.
Definitely. This is,
I
I
want to
wanted to
add over
highlight.
here, Rimpi, because I
Yes,
have
ma'am.
seen this people getting really jittery when the margins are getting involved,
Yes.
and they try to really get, a little nervous about it. So
Yes.
my understanding, what I have understood is, like after 6 months, any which way we are going to see her, we are going to actually observe her. We are going to do a relook colposcopy, and we are also going to sort of do her co-test, HPV test and all that.
Yes.
And on the relook colposcopy, in case, like suppose if you have seen a small lesion coming up, okay, and if it is amenable to ablate, as per the WHO guidelines, if it is suitable for ablation, you can still do an ablation. But if you think that next step is required, conization bhi hai, you can also do a let's if ever is required. But as Shika said, HPV is one of the wonderful markers for making us understand the test of cure. So keeping in that also is possible. So if the patient is jittery, you can treat her there and then at the 6 months ke baad. So not at that time.
Priya,
So you have to make the patient understand.
Priya, can I add one thing? If the
Yes,
biopsy
yes,
showing this,
yes, Veena ma'am, please, ma'am.
yeah. If the biopsy showing the CIN2, we can go for the immunochemistry in this patient. So it will be better guidance regarding the management or the progression of the disease. P16 or
It was not the lesion, it is only the margins.
no,
So yeah, so
the CIN2. So we can
हाँ,
go
it was
for immunochemistry.
only this ambiguity में हमें जरा सा ये लगता है,
We go
but
for the progression, or we should wait, or should we go with the extensive treatment of the patients? If P16 or is the immunochemistry is positive, we treat as a CIN3. Otherwise, we can follow up the patients and we can treat as CIN.
which we are any which way going to do at 6 months is the follow up. So
Yeah.
I think we can wait and you can 6 months we can do a relook colposcopy and then check it out.
Yeah, I also want to answer this, ma'am. In case she had got biopsy, in case she has got CIN2, then yes, the older Foxy guidelines, they are saying if it is P16 positive and you have adequate colposcopy, then you can even leave her for observation. But if she's P16 positive and colposcopy is inadequate, then you go for excision. That is just one part mentioned in the old guidelines. But actually, it is leading to extensive and it is really difficult to follow up so many flowcharts. So our patient had margins negative. Now obviously the whole of my panel is in the favor of observation. Observation protocol already ma'am has already described. So
6 months,
ASCCP after 6 months HPV based test. Foxy also says that 6 months, 1 year and 2 year, and after that she can be returned to the routine surveillance. That's it.
I think we should not use the word routine surveillance. Routine surveillance is interpreted as routine screening.
Right.
It should
Routine
return
screening.
to surveillance.
Return to routine screening.
Yeah.
In case she
Surveillance.
tests,
No, she stays in the surveillance group, not in the routine screening.
yeah, in case she is testing negative at 6 months, 1 year and 2 years. So we have
Yes.
observed her for 2 years. Now we return her to the routine screening.
Surveillance at 3-year interval with a
So now,
HPV-based
as
test.
WHO, this is the ASCP has said about three years to become more, this thing. But now WHO has definitely still mentioned only 5 years. So again, the main understanding is at least thrice there has to be a negative to put her into whatever 3 years or 5 years checkup. So that is very, very important.
Yeah, so this is the difference between our GCPR and the ASCCP guidelines, where it is surveillance 3-year, and here we are saying routine
For
screening.
5 years.
This
So
is
that
the
is
difference
what
we can just highlight, that there is a difference, and we accept it.
It's more important that she comes for follow-up.
Exactly. That's very,
Most
very
of the
important. And
time,
rather than running
Rimpi,
away for stretch
she
on.
comes for follow-up and she gets it done, not like the one who ran away today.
Today we have one patient in OPD. We spent 6 months later. She came and we asked you, "Will do your colposcopy," and she just vanished.
Yeah, that's
She did not want a smear. She said, "You are spoiling everything for me. I will not have an internal checkup." This was the two of us.
Yeah, today only. Okay, so I'm quickly going to the third case. She is a 28 years old, nulliparous, married for 2 years, some IT professional. She had postcoital bleeding and she comes to you. We did her cytology. Some PS was having small ectropions. LBC was done, which showed high-grade squamous intraepithelial lesion, that is HSIL on cytology, and recently married, nulliparous. So how will you proceed?
I think HSIL आ गया यानी कि we have to go for colposcopy. So either HPV positive or anything above ESCUS, the indication is for colposcopy, which is the best option. And then you have to find out the most vulnerable zone, and you have to take a biopsy from actually taking a biopsy, which includes the normal as well as the abnormal zones. So, and a good depth so that we can even have, if there is any possibility of invasion or something like that, we can have the assessment on pathologist report on that. So colposcopy and guided biopsy.
So this is our Foxy algorithm for primary cytology testing. If it is more than or equal to LCIL, we go for colposcopy with or without biopsy. And sorry for this image. This is actually belonging to this particular patient only, because this was showing acetocyte areas which were randomly placed in all the quadrants. There was an erosion at 7 o'clock and there was coarse mosaic pattern. So all in all, it was sweet score 10. And we did her biopsy. One fragment was showing CIN3 and there was a small focus of stromal invasion. My screen is not, that was showing a maximum depth of 0.6, less than 1 millimeter. So it was showing 0.6, then less than 3 millimeter invasion it was showing. So overall the features were suggestive of this FIGO 1A1. And what will you advise her? She is keen on future pregnancy. Young patient, HSIL,
fertility sparing can be easily done. Conization can be, fertility sparing is something which will be the best option for her. So,
conization will be the best option.
Conization would be the best in this case.
Okay. Before proceeding for conization, would you like to do any other investigation? We want
an
to
MRI to see, ACT MRI to see whether there are any nodal involvements or all that,
Yeah.
That's also very important.
Yes, it is very much recommended that when we are proceeding for fertility sparing management, we have to rule out the extracervical disease and look at the proximity to the os and local extent of the disease. And further, FDG, PET and all these things are indicated in if it is advanced stage, but ours is only 1A1. So we got her CE MRI done and there were no findings, there were no lesion, no mass, no growth obvious in the cervix. And uterus was also normal. And with these findings, radiologically also she was stage 1A. And the biopsy showing squamous cell carcinoma and MRI early stage, but practically not, no lesion. And she's keen on future pregnancy. Now what next for her? Rashmi ma'am, you want to comment on this?
This is a difficult question. Anyway, what I would have done in the first colposcopy was to take more biopsies, I mean multiple, 3 or 4 at least.
Yes, there were multiple biopsies.
And
There
I
were
would like to
4,
ask
5.
my pathologist about LVSI on those biopsies, if it is possible
LVSI.
or not. That is the question I would like to go back to them to say, if there is LVSI already present with the microinvasion of whatever you told me, in that case, cold knife conization may not be enough. Other than that, cold knife conization would be the answer for her.
Wonderful. So she did not have
LVSI, again, you can't do a conization with an LVSI. So that's exactly where the pathologist has to really give a good.
But yeah, but if they're unable to tell, because sometimes the specimens are so small, they're
So
unable
small
to
that you
comment on
cannot, yeah.
LVSI. In that case, a cold knife conization
Yeah.
with a proper size, proper depth, so that I try to get
So
that.
that becomes a therapeutic as well as diagnostic, sometimes
Yes,
like when we go with
definitely.
that,
Yes.
that really can then make us understand also.
Yes.
Yeah, in this patient also we asked them to do the more sections if it is more invasive or anything. So now we planned conization for her. Conization, nobody for leap?
No.
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 Fine, thank you.
Okay, that's what we
So,
chart,
No. For
yes, you can't
any
do it.
microinvasion or any adenocarcinoma, they are the two where cold knife is to be done.
Depth has to be quite this thing, good depth. You don't get so
Yeah.
much in a leap or a depth.
For
So
all,
you
yes.
have to do a conization.
For all our delegates, I want to emphasize it has to be an intact en bloc. Conization is recommended, and plus endocervical sampling should also be done to rule out any residual disease at the back. So we did the conization. This is her cone biopsy report, and it is showing full thickness dysplasia all over. But on extensive sectioning, they could find only small focus of invasion that was 0.8 millimeter, that was less than 3 mm. And there was no LVSI on cone specimen. Resection margins were free. Endocervical curettage also shows only benign endocervical glands. So practically she is now what stage, ma'am?
Stage 1A, 1A1.
1A1.
And
1A1.
probably you have done the complete treatment because you have taken a cone which has completely taken all the diseased area. Margins are free, no LVSI. It means you have
And then
done
we
the
do that
treatment.
only, for 1A1, it is actually conization before
And
fertility
you have
sparing.
completely done the treatment. That's not the time for surveillance.
Fine. Now, great. So my panelists are really concerned about that time. I'm really appreciate that. So this is just to summarize the fertility sparing. If it is no LVSI, then we can cone with the negative margins and with the resection margins that at least it should be non-fragmented and less than 1 mm of negative margin should be there. And in case it is 1A2 or 1B1, in case she doesn't have LVSI negative margins and it is squamous cell carcinoma only, tumor size is less than 2 centimeter, that is 1B1, and invasion is less than 10 mm, and she doesn't have any metastatic disease on this thing imaging, then you can go for this conization or plus pelvic adenectomy or for these 1A2 and 1B1. If it is with LVSI, as Rashmi ma'am pointed out, we need to do the radical hysterectomy for this patient if LVSI is there in stage 1A1. So this is just to summarize what I have said, the criteria for fertility sparing treatment. And this is already done. Rashmi ma'am has and Priya ma'am has already highlighted that in which patients would you advise trachelectomy. So our patient had negative margins. So when are you going to follow her up? How? How will you follow her up now? Bharti ma'am? I guess ma'am is not there.
There's
Shikha
a
ma'am, you can
question
take
about
over.
LVSI in the panel, like this is lymphovascular space invasion.
Yeah.
A pathologist.
Pathologist only can say this. Say
And
this.
chances for that, for lymph node metastasis are higher in the presence of lymphovascular space invasion reported on pathology.
Because it is a case of cancer which we have treated in a fertility preserving manner, we have to be more extensive in our surveillance, and it should be 3 monthly initially, 3 to 6 monthly, something like that for first 2 years, and then only we should be allow her to plan her pregnancy. This
Great,
is
ma'am.
what we feel. I don't know.
For 2 years, yes, ma'am, very rightly said. 3 to 6 monthly was history and examination and cytology. And this is 3 to 6 months, and after that, 6 to 12 monthly. And images also recommended in surveillance. we can do pelvic MRI with contrast 6 months after the surgery, then yearly for 2-3 years, and other imaging depends upon the any symptoms she has. Rashmi,
think
this one is
MRI
for you.
I'm
just
unclear, Dr. Shikha, you said that we'll allow her to plan for pregnancy after 5 years.
2
Would it
years.
be a little late? Yeah, 2 years
2
would be
years.
a
2 years.
reasonable time. Otherwise,
Yeah,
you know,
2
yeah.
years. I
Yeah.
just want to have a thing. You said MRI after 6 months. So because if the initial MRI was negative, I don't, do you feel that repeat MRIs should be done after our treatment has been
Ma'am, this is what is recommended in NCCN guidelines
Okay.
that they have written this thing for like 1 after 6 months is required, and then yearly for 2 to 3 years.
It will give us
So
an
this is
idea which is if something is developing inside, which we are not
Yeah,
able
this
to
is
see externally.
this is actually the snapshot of that. This I have summarized this thing.
Yes.
1 after 6 months, and then yearly for 2 to 3 years. And after,
Yes.
in addition to that, in case she has any pulmonary symptom or anything, you are going to look for the radiology for lungs or something, wherever the symptom based further imaging can be
Yeah,
done.
yeah. No, the MRI will pick up, you know, supposing we've removed in the cone, but there was some kind of a lymphovascular, some cells which are going
Missed
to
by
affect the lymph nodes. We
Yes,
can never
ma'am.
make it out on our clinical or
Clinical. Yes,
examination
ma'am.
or
They have
colposcopy.
recommended pelvic MRI.
Yeah,
Pelvic
yeah.
MRI.
So, Rashmi, ma'am, this one is for you. This is your favorite question: role of HPV vaccine in this patient.
I am quite a proponent of the adjuvant HPV vaccine, and so are you, Dr. Rimpi, because what we feel is that according to most of the guidelines, if the person is eligible as per the age and has not been vaccinated before, in that case, how the vaccine will help is that one is that the immunity which works by the vaccine is far higher than that which comes from the natural infection of HPV, and then it will cover more strains. But in a case patient where we already have a microinvasive cancer, probably not. But in patient with HSIL till the age of 45, if it's a risk benefit ratio, if after discussion they are okay and they've not taken it before, it may be offered. But again, this is not yet a guideline. This is only an advice of the ASCCP. And we are in a country where we should be dealing with primary vaccination rather than stressing on this at this point.
So, this is another case scenario: 37 years old, multiparous lady with irregular bleeding for 3 months, and you did a pap smear. It shows atypical glandular cell, NOS, not otherwise specified, atypical glandular cell. So, how are you going to proceed? We did her ultrasound. It was showing normal uterus. ET was 7 millimeters. And so, Shikha ma'am,
If glandular cells are atypical, I think endocervical and endometrial biopsy is an important aspect which has to be done first.
colposcopy, ECC, and endometrial sample.
Yes, yes.
We did any role of HPV testing in this patient?
Yeah, it should be. HPV is associated with both ecto as well as endocervical cancers to some extent. So
Yeah, it will just tell you, but for the management purposes, it's not going to affect the management, so you
yes,
can skip
it's not
that.
going to affect the management.
So we did her colposcopy, ECC, and EB, but this did not show anything. I mean, there are cases when we don't get anything on colposcopy and biopsies. So you are not going to leave her alone. So what is the recommendation for this patient now? She's atypical glandular cell, but we did not find anything on biopsies. Rashmi ma'am?
So have we looked properly, like endocervical biopsy, endometrial biopsy? Have we looked for
They
any
all are
polyp in
negative.
the endometrial cavity by ultrasound? We can
We
do a
did that. ET
hysteroscopic
was also
biopsy if we
normal.
feel that
Yeah. That
if the symptoms
definitely it
are
is
there.
recommended that you can discuss back with the pathologist if you are very
Yeah.
sure that you have not missed anything. Then she could be called after 1 to 2 years. In case there is no lesion found and you have done her ultrasound, you have done transvaginal sonography, and you have reviewed her ECC and endometrial biopsy, and there is no lesion on the ultrasound. So, 1 year later, again she has atypical glandular cell. Now, what is recommended?
I think बार-बार आ रहा है अभी exercise कर दे repeat repeated persistent atypical glandular cell This may lend up into something in the
Okay, fine.
future, I think. We
Now,
have
if she
observed
has
at
got,
least for 1 or 2 years, it's
yes,
not
ma'am.
going back.
Okay, this was just to highlight that yes, you can have this kind of picture where you don't find anything. In those cases, when you are sure that you have not missed anything, you can leave her for, observation for 1 year. And if subsequently the patient is under follow-up and now she has shown AIS, so what will be the recommendation? She is
I
adenocarcinoma in
would like
situ.
to do this thing, why not do an excision? Do an excision and check out, right? If you're missing out something.
मैम अभी आया ना AIS, पहले नहीं आ रहा था. पहले atypical
Wonderful,
glandular ही आ
Priya
रहा
ma'am.
था.
Thank you for joining again. So
Yeah.
excision is recommended. Ma'am, why not straight away hysterectomy for AIS? Why we want to do excision first and then why not hysterectomy 37 years?
समझो तो सही hysterectomy करने के पहले. I don't.
Dr. Rimpi, why not hysterectomy? Because you have to rule out invasion. And
Yeah.
in AIS, it is a multifocal disease with skipped areas. Endocervical glands are, no, they're not placed like the squamous ones. It's very easy to miss the invasion somewhere high up.
Hysterectomy कौन सी hysterectomy करेंगे ये भी तो मालूम होना चाहिए ना. We should know which type.
Yes.
Just
Exactly.
doing
I
a
wanted
simple
to
one
bring up
doesn't
this
matter.
point that even if she did not show any lesion in the previous one, now she has developed. One might think it is an early stage. Still, you have to do the excision to find the extent of invasion before proceeding with hysterectomy because, yes, type of hysterectomy is definitely, the deciding factor.
And this
especially
excision
when
has
it is
to be
AIS.
cold knife.
Has to be cold.
Yes, not leap.
Yes, for this it is even recommended that the depth of your cone should be minimum 10 millimeter, and if she's
10.
not concerned for fertility, the length of the cone should be 18 to 20 millimeters.
Yes.
And you cannot do this thing, you do the leap and then you do the top hat. You cannot give a fragmented specimen for AIS. It has to be intact, it has to be cone, and rather this is one of the indication where conization is preferred over leap in by WHO also. Right. So this is like we did the conization and margins are free. So Priya ma'am.
No, sorry. I'm actually on the verge to get into my OT. I'm sorry, and
Okay,
I just wanted to say that thank you everyone.
Okay.
I'm so sorry I had to leave. I have to do now I'm entering into actually for a Vardhans. So sorry. Sorry. It's a 7
All the
o'clock
very best,
posted.
ma'am.
Thank you very much. And thank you very much everyone to join. Please continue. Please continue.
So we did the conization, margins were free. So now what? Hysterectomy is already planned.
Hysterectomy.
In case the margins are involved, then
See, then it is the
margins are
pathologist who will tell you, have you got a 20 mm length cone? How much is the margin involved? Is it just at some point or is it not? Because a repeat cone may not be feasible after doing such a big cone.
In the cone, the thing is margin, apex, LVSI, these three things which has to be clear. If it is clear, then we can observe for some time. If it is anything is doubtful, like LVSI, not very sure, or margin
I
is positive,
would
or apex
differ from
has
you,
to
Dr.
be
Shikha. If I have adenocarcinoma in situ, even with margins free, and her family is complete, I would go for a hysterectomy, and that is what is the recommendation in some guidelines. The last I read was in the Australian guidelines, and in fact they said that we still do not know how adenocarcinoma will behave. It behaves differently from the squamous component, and they have a less kind of a follow up after hysterectomy. But here they recommend annual testing after hysterectomy, lifelong. So adenocarcinoma in situ is different from the squamous component. That is the guideline I refer to, which has addressed this adequately. Dr. Rimpi can.
I agree with the same. And Shikha ma'am also highlighted that if the re-excision is not possible, then also we need to proceed for hysterectomy. If the re-excision is not possible.
Yes. And it's likely not to be possible if you have done a good excision the first time.
Yes. Then it will be definitely difficult on the second time because if you have taken out adequate cone, then it won't be possible. And these are the reasons why, because there is very high chance of it being multifocal and being located in the endocervical canal, and the colposcopic changes may be just subtle. So we may not be able to pick up the good acetowhite lesion or something. So hysterectomy is indicated in even if the margins are negative. So follow-up, ma'am has already highlighted, annual follow-up रहेगा, and then after that, if she's test negative for 3 years by co-testing or HPV-based test, then ma'am want to add something?
Here, which are the guidelines which are saying 3 yearly follow-up for
Ma'am,
AIS?
first of all, it's annual follow-up for 3 years.
That is done after that.
Yeah. Annual follow-up for 3 years on HPV-based testing, and plus since May you have to co-testing or HPV-based testing, then annual for 3 years. If
Yeah.
she tests negative for 3 years, then you are going to leave her for 3-yearly
Huh.
surveillance.
So what I'm asking you, that the 3 yearly surveillance after the annual one, that is fine, but one guideline recommends annual surveillance forever. That is the Australian guideline.
Okay.
And somehow only in AIS, only in AIS. And they say the reason is because we still do not know how it will behave. But it's okay. I mean, this is also fine. But I just thought I'll bring it out that these women need more surveillance than the squamous HSILs.
So here I would like to ask the organizers, if we have time, then we can move on to the last case. Otherwise, Priya ma'am said that we should not exceed time. So do we have another few minutes or should we wind up?
I think we can wind up, Rimpi. We've already crossed the time. Yeah.
Okay. Fine. Thank you. Thank you, Rashmi ma'am. Thank you, Shikha ma'am. And special
Thank you
thanks
for
to
very nice
Bharti.
cases as usual. Rimpi does a very good panel. She is.
She has
Shikha ma'am,
collected the guidelines very nicely and
Very nice.
Thank you. Thank you, everyone. And thank you, Priya ma'am, for joining in. And thank you, Sukanya. So I hand it over. I stop sharing my screen.
Hello. Oh, hello.
Hello.
Can I post this link?
I thank the moderator and the panelists for the wonderful case-based discussion. Please post the post-test link.
Yes, ma'am.
Time is up. So we'll see the post-test answers of the day. Can you post the answer?
Yes, ma'am, just a minute.
I invite Dr. Priya ma'am to convey the answers of the day.
Yeah, so thank you very much. So again, I've rejoined. I'm waiting for the anesthetist to come, so I got a time. So here we are now posters. All the answers are all right at your thing. So fine punctuations and mosaics definitely are not this thing. It's not a feature of high grade, so that's false. Total sweet scoring is 8. We told it is 10, so that's false. Then TZ is when you see the new TZ2, when the new SCJ is near the OS with some endocervical components, so that is true. TZ is when the new SCJ is completely seen on the ectocervix TZ3. No, that is false. Definition of new SCJ is the junction between metaplastic squamous and columnar epithelium. Now, what is an inadequate colposcopy? As per we just mentioned IFCPC nomenclature, when the cervix is not visualized completely, then due to bleeding or scarring, that is inadequate colposcopy. Then what are the types of TZ? Bhagia told it very well, 1, 2, and 3. Then what is the color of the columnar epithelium? It is, you can go ahead little. Can you show us the, yeah, move little, yeah. So it is red in color. White is red in color because it's a single layered epithelium. Then ideal magnification to see vessels is 10 to 12, very well, initially also told very well by Bhagya. An optimal gynecological cytology sample should contain squamous cells, endocervical component, metaplastic cells, and everything should be there. That is true. Please move ahead. Age to end the screening is 65 years, even if the patient had a history of CIN2 5 years back. So, Nilima, can you move ahead? Can you take it up? Can we see the further ones? Who is taking the slides? Yeah, please go till down. So that is false. Who postulated the link between HPV and cervical cancers? You can go down a little bit. It is Haraz Hussain. The original SCJ is located at the caudal distendon of the new SCJ. That is the answer. You can go ahead, go down. Okay, atypical metaplasia is this thing D can grow both towards or away from the os. Then low grade lesion on cytology is abnormal nuclei in the superficial and intermediate cells. And then you have sensitivity and specificity of VIA at CIN2 is, you can see that the C is the answer for that. Then acetic acid used in VIA is 5%. HPV positive, does it mean CIN or cancer? No is the answer. HPV tests are more or less sensitive than cytology. It is definitely more sensitive with a very high good negative predictive value. Then the last question is HPV tests are more or less specific than cytology. It is less specific because it doesn't have a high PPV value. Cytology has a good PPV value, positive predictive value. So that is our question for the day. And so somebody has written out of 20, we have to get it. Yeah. So dear friends, today we have come to the end of our session. And I would like to thank ICOG to give us this opportunity. I will personally like to thank Suganya and Janani to conduct this program very, very well, very efficiently, keeping the time, albeit the fact we became 20 minutes late, but that's okay. And also all my speakers, my panelists, my chairpersons, and above all, the audience who have been waiting so patiently. This shows the interest which our delegates have towards gynae oncology. And hence, I would like to thank ICOG to take up this fantastic topic of oncology as a certification course. Thank you very much, and goodbye to everyone.
Yes, thank you, ma'am. Thanks for the opportunity.